Good morning, everyone, and welcome to Wisconsin virtually. I'm Mahua Day. I'm one of the neurosurgeons at UW-Madison, and I want to welcome everyone to the 6th annual UW, MCW, and Theta Care Multidisciplinary CNS Metastases update. It's truly a privilege to gather once again, this time with colleagues joining from across the country for what has become really a highlight in our neuro-oncology calendar. The symposium was designed initially to celebrate and advance the collaborative spirit that defines our field. And each year, we bring together experts from across leading academic and clinical institutions to share new science, emerging technologies, and multidisciplinary approaches caring for patients with brain and spine metastases. And today's agenda really reflects that commitment. You'll be hearing from nationally recognized leaders representing institutions such as Brigham, Dana-Farber, Johns Hopkins, Mayo, Sloan Kettering, UCSF, Duke, and Ohio State, and all contributing their expertise on advances in stereotactic radiation, leptomeningeal metastases, brachytherapy, and spine oncology. We are so grateful for each of you for being here to learn, connect, and strengthen the partnership that ultimately improves the outcome of our patient, not just locally or regionally, but globally. And it's truly my pleasure to turn it over to my friend and co-director, Dr. Joseph Bovey, who will share a few thoughts and guide us into the morning.
Thanks so
Dr.
much, Mahua. Yeah, it's really good to see everyone joining us virtually today. I can't agree with you more. It's truly inspiring to see how this conference has grown from really just a regional collaboration to now an internationally recognized multidisciplinary program. And we welcome our colleagues who are joining us from overseas. We're sorry if it's either really early or really late, but welcome nonetheless. Each year, we're really reminded of how powerful it is when academic partners like UW-Madison and MCW and Theta Care unite to share expertise and elevate our patient care together. Really across all of our centers, the work that's being done in brain and spine metastases management is truly exceptional. From advanced stereotactic approaches and translational biomarker research to innovative intraoperative and spine therapies, what binds us here is a shared commitment to pushing the field forward while keeping the patient's quality of life at the center of everything that we do. I'd like to take just a brief moment to thank and really give a tip of the cap to our organizing committee who has joined us. Dr. Max Krukoff from the Medical College of Wisconsin, who's a neurosurgeon there, who I've had the pleasure of working with for quite a while now. Dr. Brett Morris is a radiation oncologist at UW-Madison and has absolutely been a pleasure to work with him and to share patients collaboratively. And then one of my other colleagues at Theta Care, Dr. Harsha Pula, who's a medical oncologist who is part of his medical oncology career, really focuses on patients with brain disease and spine disease. And then to all of our presenters today, obviously, for lending their time and expertise, we thank you for joining. Before we begin, just a couple housekeeping things. Quick reminder that you can submit questions through the sessions in the WebEx chat function, which is on the lower panel of your browser. And we really encourage you to share your thoughts and questions. And we obviously have time at the end of each of the blocks this morning for our panelists to be asked questions and for people to join in on discussion. So on behalf of Dr. Mahua Day and myself and the entire planning committee, thank you for spending your morning with us. We look forward to an engaging, informative, and inspiring program ahead. I'd like to kick the morning off with introducing our first speaker. He hardly needs an introduction. Dr. Iser is a nationally recognized leader in the management of brain metastases and stereotactic radiosurgery. His work at Brigham and Women's and Dana-Farber Cancer Institute has helped define contemporary practice standards for precision radiotherapy and multidisciplinary CNS care. Beyond his academic impact, Ayal is one of those rare colleagues who combines brilliance with generosity, always approachable, incredibly collaborative, and deeply committed to advancing patient outcomes. And we're really thrilled to have him kick off our morning today with his talk entitled Advances in Stereotactic Radiation for Brain Metastases. Ayal, thanks so much for joining us, and we're really looking forward to your talk.
Thank you for that lovely introduction, mostly undeserved, but thank you nonetheless. And just wanted to say thank you to Dr. Bovee and Dr. Day and the entire organizing team for this wonderful conference. Really an honor to speak in front of you today. If it's okay, I'll share screen.
Would love that. Thank you.
And Janelle, thank you for showing me how to share screen without getting unwanted interruptions from Teams and other apps. So hopefully this will work out well. The slides are visible?
Yes.
Yep.
Yep, you are good to go.
There you go.
Perfect. All right. So it's my pleasure to speak about some of our work in advancing stereotactic radiation to new populations of patients with brain metastases. These are my disclosures. And just as a little bit of background, as we all know, when it comes to brain metastases and radiation, there's a few different options that we can pick from. There's whole brain radiation with or without hippocampal avoidance, as well as stereotactic radiation, where of course only individual targets are addressed by the radiation. These are the historical published randomized studies asking the question, can we omit whole brain radiation from the management of patients with brain metastases in lieu of focal approaches such as SRS alone? So all of these trials randomize patients to some sort of local therapy, SRS, surgery, or both, plus minus whole brain radiation. What they generally showed is that whole brain radiation does lower intracranial recurrence rates, but does not improve survival, and concerningly can compromise quality of life and neurocognitive function. Now, it's important to note that none of these studies included patients with more than 4 brain metastases, and that hippocampal avoidance techniques were not utilized. We now know, based on the CC001 randomized study, that hippocampal avoidance whole brain radiation yields better neurocognitive function than traditional whole brain radiation. So this has become the standard of care for patients who qualify for this technique. So we decided to embark on a randomized study in which patients with 5 through 20 brain metastases would be randomized to stereotactic radiation or hippocampal avoidance whole brain radiation, with the primary outcome being patient-reported symptom severity and interference. And this is work that was presented at ASCO and ASTRO this year. Patients were eligible for the study if they had a solid primary cancer other than small cell lung cancer. We'll talk about that population later on. They had to have 5 through 20 brain metastases, an age of 18 through 80, and a KPS of 70 or more. They were not permitted to have prior radiation for brain metastases, although prior surgery or systemic therapy were permitted. There was no leptomeningeal disease permitted, and patients had to have reasonable kidney function, be able to tolerate an MRI, and lack unresected, very bulky lesions. The radiation utilized was fairly standard. The stereotactic radiation relied on SRS for smaller tumors. For tumors that were a little larger, we used SRT, 30 gray and 5 fractions, except for cavities that were growth totally resected, in which 25 gray and 5 fractions was utilized. For hippocampal avoidance whole brain, we generally followed CC001 with this typical dose and hippocampal metrics. We did contour and evaluate the metastases, and one difference is that we allowed patients with tumors in or near the hippocampi to be treated on study, and essentially we treated those metastases and spared the remainder of the hippocampi, understanding that we would violate typical metrics for hippocampal sparing. And we did use memantine for the whole brain arm on this study. This was the primary outcome measure. It was symptom severity and interference patient reported using the Madasi BT instrument. And this instrument asks patients 22 questions about the severity of their symptoms and 6 questions about how much those symptoms interfere with daily function. And those questions are relatively important and include things like activity, mood, ability to work, relationships with other people, ability to walk, and enjoyment of life. We weighted the severity component 50% and the interference component 50% in composing a composite score. And we looked at the 6 months after treatment relative to baseline when computing differences between arms. We had to decide what was a clinically meaningful number to shoot for. And based on prior literature, we felt that a severity difference of 0.7 and an interference difference of 1.25 would be clinically meaningful. And this is about 50% of the difference in scores that a patient with a good versus poor performance status would typically display. Using 80% power and a two-sided alpha of 0.05, as well as some inflation for patients lacking one post-treatment assessment, 196 patients were required from the study. We did collect a number of secondary outcomes as well. This included functional outcomes, including performance status and ability to complete ADLs. Neurocognitive function was also assessed. We also looked at survival-based outcomes, recurrence-based outcomes, need for salvage therapy, and other outcomes as well. The study was investigator-initiated, supported by Varian Medical Systems, activated in April of 2017, and ultimately 4 sites accrued to this study. Originally, it was open to patients with 5 through 15 brain mets, but about 6 months after it opened, we expanded to 5 through 20 brain mets. The final patient was enrolled in May of last year. The data matured for the primary endpoint about a year ago, and the neurocognitive endpoints matured about 6 months ago. And we used an intent to treat analysis. This is the consort diagram from the study. You can see that 98 patients were allocated to each arm. Notably, there were 9 patients allocated to whole brain radiation who never received it. 5 of those patients actually refused it after randomization and ultimately were treated with IRB approval in the stereotactic arm. We did analyze intent to treat, however. And there were 4 patients who were never able to get whole brain radiation, largely due to clinical decline. There were 2 patients assigned to the stereotactic radiation arm who were not able to receive that therapy, also due to clinical decline. And what you can see in the follow-up period is that, typical for a brain metastasis study, there was dropout in the ability to collect the primary outcome measure with time, largely due to patient death. These are characteristics of patients at enrollment. You can see they were pretty comparable in terms of their age, sex, KPS, and primary cancer type. About 60% of patients in both arms had neurologic symptoms. 12 to 14% had seizures, and most patients had extracranial metastatic disease. About half of patients were on dexamethasone, and about a quarter of patients had prior neurosurgical resection. The median number of brain metastases in this trial was 14. Turning to the outcomes, this is overall and neurologic survival. So you can see overall survival was no different, and there was no difference in neurologic death between the arms either. If we examine the primary outcome measure, you can see that the Madasi symptom severity was no different at baseline, but in the post-baseline period, patients in the SRS arm did about the same post-baseline as pre-baseline, or at baseline, and patients in the hippocampal avoidance arm did slightly worse with their symptom severity, meaning more symptoms. When it came to symptom interference, no differences at baseline either. Patients in the SRS arm actually improved. Patients in the whole brain arm got worse. And ultimately, when we took the average of severity and interference, which was the primary outcome measure, we found that patients managed with SRS or randomized to SRS had a lower symptom burden and interference with daily function. And this met the primary outcome measure for the study. If we look at this in a more granular form, time point by time point through 6 months, you can see that at most time points, for most measures, be it severity, interference, or the average of severity and interference, patients in the SRS arm did better than patients in the whole brain arm. We looked to see if there was effect modification. Could there be some patients who benefited more from SRS and other patients who benefited more from whole brain? And we did not find much effect modification. The benefit of SRS was pretty consistent regardless of the subgroup that we examined. This is data for Karnofsky performance status. As you can see, there were no difference in performance status at baseline. They start to separate a little bit, not statistically different, but numerically different at 3 weeks. And at 2 months through 12 months, at every time point we assessed, patients had better performance status if they were managed with stereotactic radiation. Similarly, this is the Barthel index for ability to complete activities of daily living. We assessed it at 4 months and 12 months after treatment. And you can see that patients randomized to the SRS arm had a greater ability to complete their activities of daily living at both post-baseline time points than those randomized to whole brain radiation. This is the neurocognitive testing. And the first slide shows the HVLT. If there are any residents on the Zoom, this is an instrument where we ask patients to remember a list of words, and in different ways, shapes, and forms, we ask them to tell us the words that they remember. And that can be assessed multiple ways. But the short answer here is that we didn't see differences at baseline for any measure. And for most measures at 12 months, granted with a lower number of patients completing those assessments, we saw benefit in patients who received SRS. This is the trail-making test, COWAT and MMSE. The trail-making test is a test where patients get a sheet of paper, and in different ways they have to connect dots. And for example, the harder of the two versions has A's, B's, C's, and D's, and 1s, 2s, 3s, 4s, and so on. And they have to go A, 1, B, 2, C, 3 with a pencil and connect those letters and numbers. And we're timing them to see how long that takes. And what we found is that there was no difference at baseline between groups, but that either at 4 months or at 12 months, depending on the TRAILS assessment, patients who were randomized to SRS did better. The same was true for the COAT, which is a test where we ask patients to tell us how many words they can name that start with a given letter in 1 minute, C, A, T, whatever that letter may be. We found that patients did a little bit better if they were randomized to SRS than if they were randomized to whole brain radiation. We did not find any differences in MMSE scores, however. This is data for intracranial disease control. So patients who were randomized to SRS developed more brain mets than patients who were randomized to hippocampal avoidance whole brain radiation. However, local recurrence was less of an issue in those patients, as you can see in the middle cumulative incidence curve. There was no statistically significant difference in leptomeningeal disease between the two groups. There was also no difference in the need for salvage surgery or salvage SRS after randomization and after initial treatment by arm. And one question that we were wondering about was, would patients who had a lot of mets that we treated stereotactically need a lot of whole brain radiation to salvage it down the road? But we didn't really see that. Only about 10% of patients who were randomized to SRS ever needed salvage whole brain radiation in the future, as you can see in the right curve. Necrosis. So we did see more necrosis with SRS as expected than with whole brain radiation. The whole brain radiation never directly caused necrosis, as far as we can tell. The necrosis occurred only in patients who required salvage SRS after whole brain radiation. So the main conclusions from this study were that patients with 5 through 20 brain metastases experienced less symptom burden and less interference in daily function when managed with SRS as opposed to hippocampal avoidance whole brain radiation without compromise of survival. SRS also yields better performance status, ability to complete ADLs, and neurocognitive function. Although hippocampal avoidance whole brain radiation minimizes the likelihood of development of new brain mets, it achieves poorer local control of existing brain mets. And it's notable that we did not need a lot of salvage whole brain radiation after patients were randomized and treated with stereotactic radiation. So it's reasonable to conclude that for most patients with up to 20 brain metastases, that stereotactic radiation represents the standard of care. I'll transition to another topic that we've investigated prospectively. So this is that same table that we showed earlier, asking the question if we can omit whole brain radiation from the management of patients with brain mets. What you can see in the rightmost column is that every single one of these studies, including the one that we just presented, excluded patients with small cell lung cancer. And I think there's a good rationale for doing so. Treating patients with small cell lung cancer, as we all know, with SRS can be a little bit more nuanced. It can be sometimes difficult to even delineate the target. Some of these cases don't enhance vividly. So target delineation can be more challenging. This is just an example in the top left where you see some T1 post imaging and the corresponding diffusion restriction, because these cases often restrict diffusion. And you can see that the diffusion restriction outpaces the enhancement in some cases, in some lesions. But it's nuanced because you're not really using diffusion typically for radiation planning. So getting the target right can be more challenging for some of these cases. In addition, there's some histological data that indicates that patients who have small cell lung cancer tend to have isolated pockets of tumor cells that extend beyond the margin of the main tumor mass more than other histologies. And we don't use a CTV in radiation oncology for brain metastasis SRS. So could there be some disease that's not getting incorporated into the field for that reason? But most pressingly, as we all know, small cell lung cancer has a greater risk of microscopic disease or development of new brain metastases outside of the treating fields. So much so that there's potentially a role for prophylactic cranial irradiation for some of these patients, even if no brain metastases are visualized on an MRI scan. So we designed a prospective trial. It was single arm of patients with small cell lung cancer and 1 through 10 brain metastases, where everybody was treated with SRS or SRT. And what we tried to determine was whether neurologic death rates would be acceptable relative to historical controls with such approaches. Patients were eligible for the study if they had small cell lung cancer. We did allow extrathoracic small cell patients to participate as well. They had to have 1 through 10 brain metastases. We did allow prior systemic therapy. We also allowed prior neurosurgical resection. Patients were ineligible if they had prior radiation for brain metastases. That included prior PCI. In addition, patients could not have leptomeningeal disease, and they had to be able to tolerate a brain MRI with contrast. The SRS and SRT were standard, just like we saw in the prior study. No major differences between the two studies, actually, in terms of approach. I will point out that we did get MRIs very frequently in the post-treatment setting. So the first MRI was done 4 weeks after SRS or SRT. The second MRI was done 6 weeks later. And then we did MRIs every 8 weeks for at least a year. There was also a provision in the protocol, which we exercised regularly, that if patients were developing lots of lesions or we had concerns about their brain, we could accelerate the MRI imaging schedule. So patients had a lot of follow-up MRIs on this study. The primary outcome was neurologic death. How do you define neurologic death? Because there really isn't a standard definition, as we all know. We defined it as marked progressive radiographic progression in the brain accompanied by corresponding neurologic symptomatology in the absence of systemic disease progression or systemic symptoms of a life-threatening nature. Because of the nuance of this definition, we actually used a tribunal approach to determine whether it had occurred or not. So up to 3 radiation oncologists weighed in. We started with 2, and if there was a tie-breaking vote needed, we brought in a third. Interestingly, 97 out of 100 times we agreed, the first 2 agreed with one another. So that was nice to see. we couldn't do a traditional non-inferiority study. Obviously, this was not a randomized study. And for the residents, a traditional non-inferiority study, you're looking for a confidence interval that doesn't exceed some sort of tight boundary around a hazard ratio. Here, we look for really an egregious difference. So we wanted to see, could SRS lead to a neurologic death that was really unacceptable, meaning a hazard ratio of 1.61. What this translates to practically is a 1-year neurologic death rate of 26.7% in the trial cohort versus 17.5% in the historical controls, which were all managed with whole brain radiation at our institution. We had 90% power and a one-sided alpha, and we needed 100 patients. So we accrued those patients over about 5 years. We analyzed the study when the number of neurologic deaths that were required to power the study, which was 38, could not be attained because there were 63 competing systemic deaths. So at that point, the analysis was triggered with a median follow-up of 1.9 years. These were the demographics of patients in the study. Sorry about that. I'll point out in terms of their baseline clinical characteristics that unlike the prior study where the median number of brain mets 14, the median number of brain mets here was only 2. So that's an important caveat to this study. And about 16% of patients had prior surgery. About half of patients had been managed with prior systemic therapy for brain mets. We didn't intend to compare the historical controls to the study cohort in terms of baseline characteristics, but the reviewers asked us to, so we did so. You can see that the groups were reasonably similar, in terms of age, maybe in terms of gender. The median number of brain mets was similar. There were some differences, like the amount of systemic therapy used before radiation, for example, differed by group. Again, this is not a randomized study. Turning to the outcomes. So what we found was that in our trial cohort, the median survival was 10.2 months. There were 20 neurologic deaths out of the 100 patients. The 1-year cumulative incidence of neurologic death was 11%, and this was compared to 17.5% in the historical population that we compared to. The 2-year risk of neurologic death was 20.3% compared to 35% in the historical controls. There were 63 systemic deaths. 17 patients were alive and censored at the time of analysis. And one thing that was really exciting, and I know this number is really small, was that we think we cured actually 5 patients on this study. And it's hard to define cure, but we defined it as, and this was post hoc, patients who were alive and free of disease progression while off all therapy, including all systemic therapy, for at least 2 years. With a disease as aggressive as small cell lung cancer, being off all therapy, free of disease progression after 2 years, hopefully, suggests the likelihood of cure in many of those patients. And that was really exciting to see. Unfortunately, still a very small number. So these are the neurologic and systemic death cumulative incidence curves. As you can see, most of these patients, if they passed away, died of systemic disease, not of neurologic disease, meaning not of brain progression. New brain metastases were very common in this population. So you can see 61% of our cohort developed new brain metastases. But the frequent MRI schedule really helped because we were able to catch them relatively early, and we were able to use stereotactic radiation as salvage for most of them. So about 2/3 of patients who developed new brain mets were able to get stereotactic radiation, and about only 1/3 of those patients, meaning 22 of the patients study, needed salvage whole brain radiation at all during their whole clinical course. So we were able to spare, whole brain radiation from about 75 to 80% of these patients. So in conclusion, this study suggests that SRS may be viable in patients with SRS and a limited number of brain metastases. I would again highlight that the median number of brain metastases was 2, so we should extrapolate to larger number of brain mets with caution. In addition, the frequent MRI schedule was really imperative for the management of these patients. And then we have ongoing studies that have either been presented or are still accruing that will define this issue more conclusively, including encephalon and CC009. So with the last few minutes, I just wanted to pivot to where we're trying to go to, direction-wise as a group at our institution. So we're interested now in trying to make stereotactic radiation more optimal. It's already a wonderful treatment, but trying to make it even better. There are patients where local control is still an issue, and these are some of those patients. And they include the HER2-positive breast population, which seems to have higher risk of local recurrence than other subtypes of breast cancer, melanoma patients where immunotherapy is no longer an option, bulky tumors, cystic tumors. These are all patients that potentially could do better with stereotactic radiation. I'm not going to talk so much about the necrosis piece today, but just focus more on what we're thinking about with improving recurrence. Why do we want to improve recurrence rates? As we all know, a local recurrence after SRS can be quite problematic. It can cause symptoms and impact on quality of life. It's often a diagnostic dilemma, which can be stressful for patients. We don't know initially if it's necrosis or tumor. And then the salvage therapy often requires neurosurgical resection, which is obviously a pivotal and very, very important therapy for these patients, but carries some risk in terms of meningeal seeding and other complications. And it's not surprising that the tumor types where we struggle more with local control after SRS are the same ones where neurologic death rates seem to be the highest. So we were inspired by Camille Very's NanoRad study, which used a gadolinium-based nanoparticle called a GEEX to potentiate the effect of radiation. And they originally did a phase 1 study, which is shown here, a schema of it, which showed that this drug is fairly safe. They then moved on to a phase 2 study in the whole brain population, which was presented at ASTRO this year. And we've been taking on a phase 2 study with stereotactic radiation involving this drug, in which patients with brain metastases at higher risk of local recurrence with SRS alone are randomized to receive either SRS alone or SRS plus this gadolinium-based nanoparticle, with the primary endpoint being local recurrence. So I'd just like to conclude by saying that patients with, putting this all together, patients with 5 to 20 brain mets seem to do better symptomatically and functionally when treated with SRS as opposed to hippocampal avoidance whole brain, and doing so does not seem to compromise their survival. It also seems to help other domains like neurocognitive function. In addition, SRS may have an important role for patients with small cell lung cancer and brain mets, but we're going to eagerly await the randomized trials that are ongoing in this space. And that although SRS is a wonderful treatment that benefits patients immensely, there are still ways that we can look towards improving it, both on the efficacy and on the toxicity side. So it's exciting to see many, many trials in this space trying to address that issue. I just wanted to thank the many, many people who worked on all of these studies, and most importantly, the patients who enrolled on them, as well as their families, loved ones, and caregivers. And just wanted to thank the entire team for organizing this wonderful conference today and for allowing me to speak in front of you.
Thank you, Dr. Eisers. That was a great talk. Just for logistics purposes, we'll hold all the questions during the panel discussion at the end of the morning session. So everybody, if you have questions, please free to put them in our chat option, and we'll go through all of that during our panel discussion. And with that, I would like to invite our next speaker, Dr. Chetan Bhattacharya. Now, I don't know if you remember Dr. Bhattacharya. I first met him when I was a sub-I at Johns Hopkins, and he was a PGY4 resident.
I remember.
And that was decades ago. Since then, he was always the true surgeon scientist who asked hard questions, and he's truly the embodiment of that. And now he's the new chair of neurosurgery at Johns Hopkins. So congratulations on that. And he has evolved to be an international expert in the treatment of brain and spine tumors. His research has shaped the molecular understanding of central nervous system cancer, and his genetic discoveries have led to innovative brain cancer liquid biopsy approaches that can act as personalized biomarkers. And today he's going to talk about tumor-derived DNA as a biomarker for CNS tumors. So welcome, Dr. Badago.
Thank you, Dr. Day. Very kind of you to share those comments. And I do remember our time together at Hopkins. So it feels like yesterday, but indeed it was several years ago. Are you able to see my screen okay?
Yes.
Okay, perfect. Again, want to thank Dr. Day and the organizers for giving me the distinct privilege of talking today. We'll just share a bit about some of the liquid biopsy applications we worked on, share what others have done in this space. It's a growing and burgeoning field, so apologize that it cannot be comprehensive just due to the timing of our discussion, but hopefully we'll hit on some themes and highlights that might be of interest. So disclosures, the one that's relevant is that I have co-founded a company called Belay Diagnostics that's licensed some of the technologies that I will be using to describe our approaches. However, all the data and all the slides here are generated from our academic work here at Johns Hopkins, but important to know about that conflict of interest. So liquid biopsy approaches are growing rapidly. It's not a new concept. In fact, the idea that we can understand what's happening in a cancer by querying biofluids that are adjacent to the cancer date back many decades. One of the earliest ones is understanding that biomarkers in the stool can give us insights into colorectal cancer, was really something observed many, many years ago. Since that time, there's been an avalanche of information generated, especially over the last 10 years, where this concept of liquid biopsy has gone from a research idea to a clinically actionable process. I'm sure many on this call have used it for their own patients or contemplating using it. And so today we'll talk about its potential applications in the space of brain metastases. There are many different technologies, approaches, analytes. For the sake of time and our discussion today, we'll really focus on tumor-derived DNA, but that's in no way to discount the incredible advances and importance of the other analytes, such as circulating tumor cells, RNA-based approaches, proteomic, etc. And you'll see a smattering of some of these opportunities in our talk today. When we think about clinical applications of how to use this technology, I think there are many. We can think about it for diagnosis. We can think about it for prognosis, disease monitoring, recurrence and resistance profiling. And I think there'll be data in the talk today that hit on all of these as representative examples. And so specific in brain metastases, we can use it to help us stage cancers, understanding that the molecular composition of a brain metastasis is indeed very different than the primary tumor from which it's derived, and understanding that parenchymal and leptomeningeal diseases can also have distinct molecular profiles as well. And once we start patients on treatments, we need to be able to follow them. The idea of pseudo-response, pseudo-progression, radiation necrosis, etc., are all important concepts that each of us see on a regular basis. And of course, we need to have better opportunities to enable clinical trials with biomarkers that give us a readout, ideally in a faster and more reliable way than waiting for things like neurological change or MRI changes. So again, for today's talk, we will really just talk about one of the multiple analytes that's available in the space. It's tumor-derived DNA, for those that are unfamiliar with this. As any cell turnovers, whether it's a cancer or normal cell, it can shed DNA fragments into the surrounding biofluids, whether that's urine, stool, or blood. For today's discussion, we'll really be talking about two biofluids, blood and CSF, given our topic is brain metastases. These DNA fragments tend to be small. They're about 150, 200 base pairs. And again, the vast majority of the DNA is actually coming from non-cancerous cells that are dividing and shedding into the circulation and other biofluids. So why is it that we're interested in this concept of tumor-derived DNA? Well, one of it is because we know that cancer is a genetic disease. It's driven by a combination of genetic and epigenetic alterations that accumulate over time and space, and that these alterations really should be specific for a cancer or precancerous cell, that normal cells really should not have this in appreciable levels, and that the thought is that every cancer has at least one alteration that should be able to be targeted and tracked. The proverbial needle in the haystack is the challenge here. The needle is the tumor DNA and the hay is the non-tumor DNA. And a lot of the work that we and others in this space have done is to develop technologies that allow us to very selectively and with great sensitivity and specificity identify the needle and distinguish it from the hay. So when we think about PCR and the molecular technologies that have been available to us for many years, one of the challenges is that the sensitivity is just not sufficient. We know that often the abundance of tumor-derived DNA can be much lower than 1%, much lower than 0.1%, and we know that we needed to have new technological advances to allow this to be a reality. And we won't spend too much time on the actual technologies unless people have questions later on in the panel discussion. But one of the seminal papers in the space was published in 1999 by Bert Vogelstein and Ken Kinsler, where they introduced this concept of digital genomics. And it's really a very simple concept. The concept is that we would identify each molecule of DNA, uniquely query it, and then understand if that molecule of DNA is either a wild type or a mutant molecule. And over time and years, we have really converged on using next generation sequencing. And for those folks who are not familiar with the readout, you get these unique line items representing unique molecules of DNA, and one can say at a specific base pair, is it wild type or mutant? And this is not just a binary readout, it's mutant, it's wild type. It's actually, as you can see, very easy to quantify using the current bioinformatic tools that are available. And so there are many technologies. Again, for today's talk, won't spend too much time getting into the details of these technologies, but important to know that it's a changing and evolving field where really every day, every week, people are coming up with new and more clever and interesting both experimental approaches as well as informatic approaches. So how do we apply this for the things that we discussed earlier in brain metastases? And one of the challenges, of course, in taking care of individuals with brain metastases is occult leptomeningeal disease. We've all seen patients where we have suspicion that they may have LMD, but really hard to pinpoint definitively in some cases based on radiographic imaging. And this was a really interesting study published a couple of years ago by the group at Memorial Sloan Kettering, where they looked at individuals who were getting a CT myelogram. And as a part of the CT myelogram, a needle is injected into the thecal sac in the lumbar spine. Contrast is introduced, and that contrast spreads throughout the spine and the spinal nerves and allows us to understand where the spinal cord and spinal nerves are to help us to do our surgery safer, and in this case, to do radiation planning. And in this clever study, what they did was to take the CSF from the time of the CT myelogram that was being performed as part of standard of care, and they tested it. And they tested it with a very rudimentary technology, CSF cytology. It's been around for decades. And what they saw was that indeed, in about 16% of cases, individuals who had spinal metastases but no clinical signs of leptomeningeal disease actually had evidence on cytology of spread into the thecal sac and inside the CSF space. And so this is suggestive that perhaps many patients that we see are at risk of developing leptomeningeal disease or have subclinical leptomeningeal disease, and that perhaps by introducing some of these more advanced molecular diagnostics, that we could potentially molecularly stage these patients in a more robust and accurate fashion. And so it was a provocative study that requires follow-up, but was very interesting. We see this scenario sometimes in the clinic. It's a person with a newly diagnosed frontal lesion that's enhancing, has edema on MRI scan, and the differential can be everything from brain metastasis to primary neoplasms like GBM and CNS lymphoma. And sometimes it's helpful to know what it is, to be able to counsel patients, especially those that are older or unwell or reluctant to have surgery or biopsy. So stratifying ahead of time and aiding in diagnosis certainly is a space that we can use a molecular biomarker in the clinic today. And there's been work done, and this is a beautiful paper published in 2023 in Neuro-Oncology, that we can actually use methylation profiling to help segregate the categories into distinct buckets. So perhaps there's a day where we could do blood tests or CSF tests and profile that ahead of a therapeutic treatment, whether that's surgery, radiation, or systemic treatment like targeted or chemotherapy. And so aiding diagnosis is an avenue that can be used. And you can see that the performance with the area under the curve in this study, which of course is smaller and needs to be reproduced in prospective fashion, is actually quite robust, greater than 90% sensitivity here. One of the things that we have seen in the literature with brain metastases is that there is genetic heterogeneity. And this is a study, again, published a couple of years ago, looking at lung cancer and the brain metastases and showing the concordance between the primary tumor and that from the tumor. This is not a liquid biopsy study. This is more about testing the tumor tissue itself from the lung and brain met. And you can see that indeed there is a sort of shared population of variants, but you can see in orange there in the right panel that there are several brain metastasis specific alteration that is derived with the tumor evolution, and understanding that may allow us to have insights into how these tumors are going to behave. And you can see here is sort of their schematic of sort of the new mutations that are found in brain metastases in orange. So there have been sort of an increasing number of papers talking about detecting leptomeningeal disease specifically. This is using a CSF test that detects tumor-derived DNA. This was one of the early papers published by the group out of Stanford, led by Melanie Gephardt. And this was looking at a patient who had brain metastases from melanoma and developed leptomeningeal disease. And what they were able to do in this case report was to longitudinally sample the CSF and look for tumor-derived DNA. And what they saw was that indeed, the y-axis is the mutant allele fraction, sort of quantifying how much tumor-derived DNA is in the CSF. And what they saw was in the early phases of disease, really more than half of the DNA in the CSF was derived from the tumor. Patient had a robust response to therapy, unfortunately recurred and had a recurrence that was also seen in the molecular test in the CSF. Understanding that we could use that to potentially track tumors over time was an important finding from their paper. It's not just leptomeningeal disease that can be detected. This is a paper published by Chang and colleagues that showed that indeed intraparenchymal metastases are also detectable in the CSF, and this is in a cohort of primarily lung and melanoma patients, but also some colon and renal patients, that indeed CSF, which is the green bars here, had the ability to discern mutations in intraparenchymal metastases in genes such as TP53, KRAS, and EGFR, and that the ability to do that in CSF in this study was higher than in plasma, which is in this sort of orange and red bar. And you can also see again that the mutant allele fraction in some of these cases is extraordinarily robust, ranging anywhere from 1% or less than 1% to greater than 90% of the DNA that they're seeing in the CSF is going to be derived from the tumor. And so very interesting data coming from this study. How about after adjuvant treatment? What is the literature out there? And this is an interesting paper published in Nature Communications several years ago, and I found this really intriguing because they looked at cohorts of patients, and again, you can see the numbers are small, 7 patients to 5 patients, where they had restricted disease in the central nervous system. These patients only had detectable mutations in CSF, and those patients who had both CNS and non-CNS disease had tumor-derived DNA in both biofluids, and what they found was indeed levels of tumor DNA, both in plasma and CNF, can change in response to treatment. And so that was a very provocative paper that they published. This was followed up in 2016 by the Memorial Sloan Kettering group that suggested that not only are we able to see changes in levels of tumor-derived DNA, but in fact, we can see specific resistance mutations being developed. And they showed that patients who were being treated with either BRAF or EGFR inhibitors initially over time developed escape mechanisms in the form of new genetic alterations that made them resistant. So again, tracking disease response using liquid biopsy approaches, these were some of the early data suggest that that was feasible. And they were able to show that these changes in the CSF tumor DNA levels correlated with MRI and clinical changes as well. So our interest in this space, and that's just a brief overview of what's in the literature, and there's many, many other papers, but just wanted to give folks a sense of what's been done out there. And now we'll switch to a couple of papers we've been interested in this space and what our efforts have entailed. And one of the things we have wanted to do is develop an off-the-shelf assay. We know that the genetic heterogeneity is vast, that a patient who has a colon cancer metastasis to the brain will have genetic profiles that are distinct from an individual with a breast or lung or melanoma, etc. And so we wanted to have a test that could easily capture all of these sorts of patients. And one of the concepts we've tried to leverage is this idea of aneuploidy. Many of you are very familiar with this, but for the learners on the Zoom, this is the idea that cancer cells have an improper collection of chromosomes, that over their multiple divisions, that they lose the ability to maintain the fidelity of a normal chromosomal number. And sort of the abnormal chromosomal number is a characteristic of 90+% of cancers. And this was a beautiful paper by the Harvard group that demonstrated that. And so we thought, gosh, could we use this phenomenon seen in the vast majority of cancers as a universal biomarker? And this was brilliant work done by Chris DeVille, who used this concept that there are repeat elements throughout the genome. There's about 350,000 of these repeat elements. And Chris developed an assay called Real Sequencing System that simultaneously amplifies all 350,000 regions, uses complex informatic technologies to understand whether the tumor or the liquid biopsy sample has a normal complement, which is here in the bottom panel, or an abnormal complement. You can see these red bars above and below showing different chromosomes having aneuploidy related alterations. And so we use this technology to look at a cohort of patients, and this was a couple of years ago. Amongst those patients were individuals with brain metastases, in addition to individuals with GBM, CNS lymphoma, medulloblastoma. And the nice thing about this assay is it takes 1 ml or less, and we amplified the repeat elements, and we use 2 cohorts, a training cohort here that you can see of 92 patients, of which 14 were metastases, and a validation cohort, which was a separate group of 52 mets in addition to other cancer and non-cancerous conditions. And we began by initially establishing an aneuploidy score that allowed us to distinguish normal from abnormal. And once that score was obtained, we then applied it to our validation cohort. And these are the types of subchromosomal changes that we saw in individuals. You can see here in the right panel, there would be 2 amplification in an individual with breast cancer metastasis. And so we really could see some of the canonical driver events that we see in many of these cancers. So we applied this, and this was the overall performance. When we looked at individuals with cancer, in our training and validation cohorts, we're somewhere around 70% sensitivity, which beat the sensitivity of cytology, which was around 25%. And in this cohort, the CSF sensitivity was better than the matched plasma. And we said, gosh, what is the clinical utility of this? I'll just show you a couple of anecdotes. Again, huge grain of salt, because these are retrospective. They were caveats. These are cases of individuals that need to be further validated, but I think shows the potential of using these molecular tests. So this is a person with suspected leptomeningeal disease with a history of breast cancer who had this MRI scan. The CSF test at that time point was actually positive for tumor-derived DNA, but the MRI was negative. 6 weeks later, the same person comes back with progressive symptoms, and we can see the diffuse disseminated leptomeningeal disease. So sometimes these molecular tests might actually precede radiographic changes. This was sort of the summary of what we were able to find. 75% of individuals with metastases to the brain that we tested were detectable with just aneuploidy alone, but we want to know if we could actually get better. And so we used a different technology. Again, won't spend too much time on this, but this is a technology that allows us to really get to very high sensitivity by using what's called duplex sequencing, understanding if the same mutation is found on both strands of the DNA molecule. And the bottom line is the benefit of this type of approach allows us to go from a background, and this is in one sample, looking at the TP53 gene using our prior technologies. You can see all these little bumps and questions, and this is across the TP53 gene on the x-axis. And on the y-axis is sort of the frequency that we're seeing these mutations, and it's hard to distinguish which of these is actually real and which is just background. And with these technologies, we can identify what that background is and what is true mutation, and allows us to bump our sensitivity from 1 to the minus 10 to the 5th to really 1 to 10 to the minus 7th. So a couple log-fold improvement in our sensitivity. And so we said, gosh, we have a new sensitive technology. How can we use this? And we combined it in a recent paper we published earlier this year with different analytes. So we used the copy number changes that we were using for the first study. We combined it with the panel of 121 amplicons of the most common mutation found in primary metastatic cancers. In addition, we were able to use it to help profile T and B cell receptors. We know that we're not only interested in what's happening to the tumor, but we also want to know what's happening with the immune and other microenvironment factors. And so this assay allows us to do that simultaneously, and it requires about 2 mLs of CSF. So it was an interesting platform that we used, and we applied it. This is a schematic showing the 3 components of this multi-analyte test that we called CSF BAM, B and T cell receptors, aneuploidy, and mutations. And this was the cohort that we applied it to, including a population of patients with brain metastases. And this is the workflow. We were able to use primers to amplify the B and T cells and incorporate that into our aneuploidy and mutation workflows. And through informatic approaches, we're able to identify tumor-derived or immune cell-derived DNA in the CSF. And so we had 3 cohorts here: an analytical cohort, a separate training cohort, and a validation cohort. And this allowed us to set thresholds, understand what the performance was going to look like. And each set included a different set of samples, so we were not overfitting our data. And this is sort of the schematic of what we were able to identify. And you can see here in the metastasis group, and again, small numbers, 25 patients total identified. The composite CSF BAM score allowed us to reach a sensitivity of around 90%. And so really an improvement in the performance when we're just using aneuploidy alone. And in cases like CNS lymphoma, we saw peaks associated with the B cell population that comprise that cancer. So giving us useful information across a variety of different cancer types obviously needs to be validated in prospective fashion. What are some of the factors that impact performance? We know that indeed where these tumors reside within the central nervous system, if they're adjacent to a CSF space, if they're enhancing, actually increases the probability of us being able to identify these tumors. So there are biological processes that impact our sensitivity. Again, a couple of small anecdotal pictures to show the potential of a molecular test like this. In panel A, a patient who actually has a GBM, had radiation treatment and signs of pseudoprogression, and this patient was taken back to surgery and found at the time of resection to have pseudoprogression. Their initial CSF sample indeed was negative, consistent with the idea that this was pseudoprogression as opposed to active disease. The bottom panel is a patient who had a BRAF mutant glioma that had already had a resection and unfortunately didn't have testing for BRAF, but we were able to detect it in the CSF, and over time the tumor enlarged and needed treatment. But one can imagine a scenario today where if we had a molecular test to identify a targetable mutation by a liquid biopsy approach, perhaps this young person could have been started on a BRAF inhibitor rather than just conservative management, which just allowed the tumor to grow in size over time. So just anecdotes, again, need to be proven in prospective fashion. So where are other areas that people have worked on? So Max Dean, a luminary in the field of liquid biopsies at Stanford, put out this interesting paper about a year or so ago, which looked at lung cancer patients with suspected leptomeningeal disease. And this was their study design. It showed that patients were longitudinally monitored for both systemic as well as CNS relapse, and they had serial samples taken of both plasma and CSF, and they used a technology very sensitive that's different from ours called CAP-seq, but similar concept using next generation sequencing. And what they found was that, first of all, the plasma-based mutations actually looked quite different than the time-matched CSF-based mutations, again, suggesting that the plasma is probably enriched for systemic diseases and metastases, whereas the CSF is showing what's happening in the brain metastases. And you can see that really quite a disparate population of mutations, which we have seen from other studies. And what they demonstrated was that if the CSF was positive for tumor-derived DNA, these patients had a far worse prognosis. The positive cases were in red, and you can see that unfortunately over half those patients succumbed within 8 months or so of their positive CSF tests. And this was even the case when they included individuals with both definitive and possible LMD, that those patients do worse when CSF is tumor DNA is being detected. Caveat here is, again, small populations, needs to be validated prospectively, but a provocative study nonetheless. Where do we go from here? You know, there's been this avalanche of data. I showed you just a few representative examples of the wonderful work being done in this field by our group as well as many others. And I think this work has really propelled the NCCN Guideline Committee for Central Nervous System Cancers to think critically about this. We know that they help us with guidelines for treatment of cancers throughout the body. And in 2023, for leptomeningeal diseases, they in fact included a statement that says that CSF tumor DNA should be considered for leptomeningeal disease. In the 2024 version, they added CSF tumor DNA for the monitoring and diagnosis of tumors like medulloblastoma, ependymomas, CNS lymphomas. So gradually more and more of these cancer types are having liquid biopsy approaches being recommended as part of the workup and evaluation. And so suspect that as more data comes out, we'll see more and more comments and recommendations from groups like the NCCN, but need prospective studies to get us that level of data. I'll just stop here and say that biomarkers for brain metastases are rapidly advancing. We really need prospective trials to bring the technology in the variety of forms that are available into clinical utility and understand what patient would benefit from what type of test. And really, as I hope the last set of experiments that I demonstrated show that a combination of technologies and analytes are likely to be best. I often get asked at talks like this, which approach is the one we should be doing. Like many things in medicine, it's really adding to the armamentarium as opposed to picking the one solitary best thing. I think that applies here in liquid biopsies, that really we need all these different approaches to be vetted, tested rigorously, and those that meet the standards be brought forward to the clinical realm. So with that, would like to thank and acknowledge our funders, as well as the Ludwig Center for Cancer Genetics, in which I'm one of the PIs, co-directed by these three individuals who are close friends and mentors, Nick Papadopoulos, Ken Kinsler, and Bert Vogelstein. And really appreciate, again, the opportunity to share this work with you today. Thank you so much.
My gosh, that was just a wonderful and insightful talk. Thank you so much. I certainly have questions. I can't wait for our panel discussion. So this is just cutting edge and exciting, and so happy to see this technology actually making its way to the bedside. I think that's just wonderful. So we'll move on to our next talk. It's just an absolute pleasure to introduce a good friend and colleague, Will Breen, where he's joining us from Mayo Clinic. Just have absolutely enjoyed seeing Will's career take off there, and really have just come to know him as someone who's meticulous and really patient-centered approach to CNS radiation oncology really sets the bar for excellence. His expertise in craniospinal radiation and leptomeningeal disease has really influenced both clinical practice and clinical trial design nationally. I've always admired his thoughtful balance of science, compassion, and clinical precision. And he's going to share today a talk entitled Craniospinal Radiation for Leptomeningeal Disease, which is a nice springboard off of the last talk that we saw. This is a challenging yet increasingly important area of care. So thanks so much for joining us from Minnesota, and it's good to see you, and I'm looking forward to your talk.
Well, thank you very much, Dr. Bovey, for the extremely kind words. It's an honor to be here, and certainly a challenge to follow up those great speakers. But I'll do the best I can here. So let me know if this is sharing for me. Does that look okay?
You are good to go.
Good to go. Okay. Well, thank you again for the kind introduction and the opportunity to speak today. I'm going to talk about craniospinal irradiation for leptomeningeal metastases. So in terms of disclosure, as Dr. Bovey mentioned, I work at Mayo Clinic in Rochester, and I think in this context, it is important to note that we do have a proton center, because some of the talk here around craniospinal irradiation centers around proton treatment. As I'll get to, I think IMRT is also an excellent option, and so I don't think that this is a talk that's only relevant to people at proton centers. I think that with modern treatments, it's relevant for everybody, and I use both proton and IMRT CSI on patients in clinic, on trial and off trial, and so I think that's important to know. No other relevant disclosures for this talk. So in this talk today, I'll very briefly talk about the presentation and diagnosis of LMD. It's really critical because sometimes you're in a tough situation of not being 100% sure if you have the diagnosis or what steps really need to be taken to confirm things before pulling the trigger and going ahead with a treatment that does come with risks and side effects. When we know that this is a disease that can move rapidly. And so it can often be a really fine balance between gaining diagnostic certainty and knowing when to pull the trigger on craniospinal irradiation for patients with suspicion for leptomeningeal disease. We'll talk about the rationale for CSI for leptomeningeal disease, and particularly focus on the really recent clinical trials that have demonstrated potential benefit here from CSI, as well as ongoing trials. You'll notice as I go through the papers that these trials are all recent. All the studies that get cited are in the last 5 years, which is great for this devastating condition, that there's been movement and hopefully improvements in outcomes for patients. And then very briefly, I'll kind of talk about, some nuts and bolts of how we do proton and VMAT CSI, of course, with the disclosure that there's more than one way to skin a cat. I learned that phrase is about catfish recently, but there's different ways to do it. And it might be less interesting for the non-radiation oncologists in the group, but we have kind of written out guidelines of how we do it. And if anybody was interested in those, more than happy to share. So I'll start out with a case. This was actually a patient that I first saw in a video visit on Monday of this week. So she's a 54-year-old middle school English teacher. She had never smoked, and she just started having kind of worsening, intermittent but progressive headaches overall. And so she went and got a CT scan. It showed a right frontoparietal mass that she had resected by neurosurgery. And this was her initial diagnosis then of a EGFR mutant non-small cell lung cancer, adenocarcinoma here, limited disease outside the CNS, doing great symptomatically. She had this resection. This is the post-op scan, as you can see here, a good resection. There was still one intact brain metastasis in the left cerebellum here, but she, continued to have headaches. Really, maybe felt like she was having some cognitive blurriness, but otherwise really doing well. And so I saw her in a video visit, and to discuss doing radiosurgery to the postoperative cavity as well as this intact lesion. And so actually yesterday she came in and got her MRI for radiation planning. You might notice the fact that this MRI was yesterday means that my slides weren't done until last night at earliest. That's correct. Thank you. Thank you for the patience with me, and sorry about that, Janelle. So this was my MRI yesterday morning. And as you can see, there's clear enhancement here in the cerebellar folia. You can see, this is more than we would expect here on the same cut. You can maybe see some enhancement along the front of the optic chiasm. An area that I'll mention again, that kind of my first place I'll go to look when I'm wondering about leptomeningeal disease is within the IACs. If you can see enhancement along the 7th and 8th cranial nerves, that's often kind of a smoking gun for leptomeningeal disease, which can be subtle and can be challenging. Even there's often cases where the radiologist or neuroradiologist may not pick up on it, and so it falls on us to really be keeping a close eye out for this. And then a third scan here, again, you can see along cerebellar folia, you can see increased enhancement, as well as along bilateral trigeminal nerves here coming anteriorly. And so we see this MRI scan. She was driving back to Indiana, and we get on the phone and call her, and have to decide what to do next here. And so the questions kind of facing us at this point are, what are the further diagnostic steps are needed for leptomeningeal disease, if any? Is it good to go ahead with treatment now? Do we need further steps? And we'll talk about that. Is there further staging of the leptomeningeal disease needed? It involves the whole compartment. We already see it's there. Do we need more scans or more tests? And then finally, what's the recommended treatment? That's what the patient wants to know. She hasn't had any systemic therapy yet, as an EGFR mutant tumor. What should we do next for this patient? And so we'll hopefully address all these issues as we go through this brief talk this morning. So as some broad background, and we heard some of this in the last talk, and we'll hear more in the next talk. Leptomeningeal disease is spread of cancer cells in the CSF-filled membranes encasing the brain and spinal cord, and that's an obvious point to us here, but for learners, a key point that the CSF along the brain and spinal cord is one continuous space. And so any treatment that we get to that's only addressing part of that space will be, by definition, missing some of the known cancer cells, and may be a less effective treatment. The numbers of incidence of leptomeningeal disease are really variable from study to study. Overall, maybe 2 to 5% of cancer patients, most commonly happening late in the course, as we could see from our patient here that I showed today. It can also happen at the time of diagnosis in some patients. And we know there are some primary histologies that come with higher risk of leptomeningeal disease, classically breast cancer, potentially over 10% of patients, non-small cell lung cancers, melanoma patients who develop this devastating step in their cancer process. And it may also be more common in the postoperative setting. This is hard to say anything definitive here, but in theory, if there was tumor spillage at the time of surgery, that could increase the risk of dural nodular disease or leptomeningeal spread. This is part of the backdrop for the currently ongoing NRG clinical trial that's comparing pre-op versus post-op SRS for parenchymal brain metastases, with the thought that maybe doing radiation pre-op in that setting would reduce the risk of this type of spread. But I would say that's still an unknown, and that's still something that we'll determine, and kind of gets at a question of how can we reduce the incidence of leptomeningeal disease. That isn't really the focus of this talk, but I think is a really interesting conversation. Along those lines, I think the incidence of leptomeningeal disease is likely increasing for a few reasons. One is the improved imaging that we have, better brain MRIs to see this sometimes subtle enhancement along the IACs or along the cerebellar folia or in the sulci supratentorially. Maybe that patients are living longer with better systemic therapies and so have more time to recur. And then finally, even with the amazing improvement in many systemic therapies, there are still some of them that have lower CNS penetrance, meaning patients, even when they're well controlled extracranially, will be at risk for progression of disease in the CNS. When patients develop leptomeningeal disease, this is typically come with significant and rapidly progressive symptoms. We hope that, from, as we just heard in the last excellent talk, if there can be better CSF, circulating tumor cell or cell-free DNA assays, that this could be found earlier when it's less symptomatic and it's less of an emergency oncologically, and treatments can be initiated then, that would be great. But as with the current clinical practice, it is common that when this is diagnosed, people are in rough shape and they're in the emergency room or in the hospital, and symptoms move quick. Common symptoms here really relate to the location of the leptomeningeal disease within the craniospinal axis. Headaches are very common, as we had in this patient. Double vision, if there's tumor coating cranial nerves in the cavernous sinus or along the optic canals. Facial pain or weakness. Sometimes patients present with a picture that's like trigeminal neuralgia or like Bell's palsy. Tongue incoordination, difficulty with swallowing or speech. If there's spinal involvement, some patients can have incontinence, and then gait and balance disturbances are common with posterior fossa involvement, spinal involvement, or diffuse involvement here. So here are some imaging characteristics. Here I have an arrow pointing to the IEC again. For me, this is kind of the one of the easiest places to look to see if there's increased enhancement in the IECs, to kind of really have you on the lookout for leptomeningeal disease elsewhere. Some patients will have clear sulci enhancement supratentorially, and even looking at left to right to this patient, you can see the clear sulcal enhancement here in this patient, which is characteristic of leptomeningeal disease. A couple more pictures. This patient had more of a nodular picture in supratentorial sulci. And this patient had both supratentorial and infratentorial nodular disease. And sometimes it can be difficult to tell if it's a parenchymal met or is it a leptomeningeal area. And it really takes the whole picture and looking at the location of different spots to try to sort it out. And don't forget the spine. We're focusing mostly on the brain here, but especially in the cauda equina. So your lumbar spine is probably your highest bang for the buck of the spinal MRIs here, and you can see that there can be increased enhancement in the spinal canal, along the spinal cord, and along the cauda equina. Excuse me. So diagnosis here is a combination of three things: those clinical symptoms, those radiographic features, and of course CSF findings, which we already have heard about and we'll hear more about today. Patients can be symptomatic before they have MRI findings. And what that means is, and this kind of classic, patients are having cranial nerve symptoms out of proportion to the scan. That means that a negative MRI does not preclude the diagnosis of leptomeningeal disease. And so if someone has symptoms that are suspicious and they have a negative MRI, that often means maybe a lumbar puncture should be performed, or further imaging or further clinical testing, and sometimes it can be a process to land on this diagnosis. Similarly, while positive CSF cytology is the gold standard for diagnosis of leptomeningeal disease, it's not mandatory for a diagnosis or the initiation of treatment. In our practice, it has been not uncommon that for one reason or another, patients don't have a lumbar puncture performed. As we've just heard, and we'll hear more, there is prognostic and predictive value potentially to the CSF, looking at circulating tumor cells and cell-free DNA that add additional value, but it's not a completely mandatory step for diagnosis here. There are limitations with circulating tumor cells and cell-free DNA. One, as we've heard, there's great investigators at Hopkins and elsewhere who are working to make this more available commercially so that people have the opportunity to do these assays to check for circulating tumor cells, cell-free DNA, but they're not widely available yet in many clinical practices. When they are, the turnaround time is sometimes not as fast as what's needed for the clinical decisions in these sometimes urgent clinical situations. There will be, of course, for different tumors of origin, there may be different sensitivities or different assays that are needed. And so, I would say that's a really exciting area that is continuing to be developed. In terms of treatment here, whole brain radiation with focal spine treatment, which we'll sometimes call involved field radiation for the rest of this talk, for symptomatic disease is a cornerstone of palliative treatment here. It's effective for relieving symptoms in many patients, but it does not seem to halt progression of disease along the leptomeningeal space. And this makes sense, right? This is logical. We're only treating part of the CSF, which is involved. You'll potentially improve the symptoms for the disease, the gross disease in that area, but you're leaving microscopic disease untreated. And it's consistent with clinical experience that when you do this, it's very common that they will, have a symptomatic recurrence along the craniospinal axis in areas that were not treated by radiation. But this approach is supported by NCCN guidelines to do the standard whole brain treatment and spine treatment. It does not seem to improve survival compared to supportive care alone. So it's a palliative symptom to try to help with neurologic symptoms and try to maintain some neurologic function, but it is a limited treatment in that sense. Along those lines, the historical median survival is 2 to 5 months, and so this is really, as we know, a really serious situation. Brain metastases are a serious situation, and this is even more a dire circumstance. Many of the trials you'll look at that are small trials for systemic therapies or intrathecal therapies may have survival measured in days or weeks from the time of registration on the trial, just to show kind of where we're starting at for a baseline and how much improvement's needed. And so, along these lines, there's strong rationale for craniospinal irradiation for leptomeningeal disease because it's treating the entire CSF space, right? It's treating all of the microscopic disease here. Proton CSI may have less toxicity compared to X-ray-based 3D conformal photon CSI. And so this was determined for medulloblastoma patients over the last 10 to 20 years. And so significantly in the series by MD Anderson, significantly less weight loss with proton CSI, significantly less nausea and vomiting, less esophagitis, likely less effects on lymphocytes and platelets here. And you can see this for the non-radiation oncologists in the group. This difference is entirely due to the differences in dose spillage anteriorly. With the proton CSI, the dose stops on a dime and it doesn't exit in any significant amount through the anterior organs like the stomach and the bowel and the heart and the lungs. And, in many cases, all of the bone marrow of the vertebral column. Whereas with especially 3D, so an older form of photon radiation, there was quite a bit more dose going anteriorly. And so patients had higher risk of getting nauseous, not making it through treatment, having severe cytopenias. And so while it always made sense to treat the craniospinal axis, with the technology at the time previously, it wasn't safe, especially for a palliative treatment. It didn't make sense to be doing a lot of CSI. As I alluded to, we see that dosimetric benefit in protons, but modern photon treatment with VMAT is significantly better than 3D conformal radiation or the old school photon treatment. There's less dose heterogeneity, there's better plan robustness, much less dose to nearby organs, potentially reduced risk of secondary malignancy. In the pediatric CSI literature, less of a consideration here. But here's a IMRT CSI patient of mine, and you can see even the 5 gray isodose line, there's some spill more than a proton plan, but it looks pretty good. And you have quite a bit less dose than the old 3D plans. This is a patient of mine who is just coming back for his 2-year follow-up for IMRT CSI for leptomeningeal disease, and is doing well. And so I think that really when we talk about CSI, we're talking about modern CSI techniques. Proton therapy, of course, as we'll talk more about, but also good modern VMAT plans. So, along these lines, the thought that CSI may be helpful for these patients, the group at Memorial Sloan Kettering, led by Jonathan Yang, has really been the leaders in this field. Their initial trial, they demonstrated that between just this 1 year in 2018 to 2019, they enrolled 21 patients that were overall pretty young, 70 KPS, which is pretty good for a leptomeningeal disease cohort. Most commonly, of course, non-small cell lung cancer and breast cancer are most common primary sites for this. They showed a median overall survival of 9 months. This is really, really good. This is a disease that's often measured in weeks and days, and so getting to 9 months, even in this small trial, that's exciting. And this is almost entirely driven by the CNS progression-free survival and of 7 months. And so really the benefit here is driven by getting control of the CNS. And on many of these studies, a recurring pattern you'll see is that a CNS PFS is very closely followed by the overall survival by 1 to 2 months. And I think the reason for that is very often after a brain treatment or a spine treatment, if there's further leptomeningeal recurrence of disease, that's often the time when patients are, potentially going to a hospice type situation because they may not be candidates for further systemic therapy. It's a symptomatic progression often at that point that would limit future options. And so really the CNS progression-free survival can drive the overall survival in these patients. And so improving that, may lead to improvements in overall survival. Looking at their toxicities in the short term, really the grade 3 and 4 toxicities were relatively rare. By far, the most common ones were lymphopenia. So again, from treating the circulating blood and the vertebral bodies, decrease in lymphocytes, and then some fatigue. And so these are the things we always talk about with patients with this treatment: fatigue, drop in blood counts, potentially nausea, much less of that with modern CSI techniques, and then hair loss and potential for neurologic symptoms. We always give these patients memantine. CSI is safer, but it includes whole brain radiation. Much of the toxicity from CSI is driven by the whole brain component of it. And so the ability for protons or IMRT to allow the spinal component of it to be more safe, is really helpful. And here again are just demonstrating that the risk of grade 3 or grade 4 toxicities was really low, exception being lymphopenia is common in this patient group. And so following up on their phase 1 results, they went to a phase 2 trial here. That's kind of the star of the show over the last few years. And so they decided to do this in a randomized fashion. So take patients with LMD, primarily from breast or lung cancer, stratify them, and then randomize in the 2-to-1 fashion between proton CSI versus the standard of care involved field radiation therapy, which includes whole brain radiation plus focal spinal treatment as needed. So proton CSI versus photon whole brain and focal treatment is needed. And then patients with other histologies weren't included in this randomization, but they were kind of treated on the separate arm where everybody got proton CSI. And so, at a median follow-up of 9 months here, they had a total of 63 patients here, 42 patients in the proton CSI group, only 12 had CNS progression, which is, a really good number. Whereas in the group of 21 in the photon, 16 had CNS progression. And, you can already tell that this is gonna drive our outcomes here. And so here's the CNS progression rate with really a remarkable 6-month difference of 92% CNS progression for those getting whole brain and focal treatment, which again makes sense when you're leaving a portion of the craniospinal axis untreated, versus just 22% in the proton CSI arm. And so this was what really drove outcomes. And that, that CNS PFS difference here with a median of 7.5 versus 2.3 months did kind of surprisingly translate to a difference in overall survival. So a 4-month difference in overall survival. One thing that I think is really key to notice about this chart is the control arm here. So the group getting whole brain radiation and spinal focal treatment had an overall survival of 6 months, which is much better than many clinical trials of promising therapies. And so their control arm did really, really well. So that might tell you these are really well-selected, carefully selected patients that are really, good candidates for this. And they may have been good candidates for further systemic therapies and had other good options. So I think that's an important note to make about this. So after this was published, I remember it well. We were all really, really excited about this. This is a disease that had really no good options, very few trials that had improved PFS, let alone OS. And so many of us started doing CSI for leptomeningeal disease kind of off trial, partly at our medical oncologist who saw the presentation by Jonathan at ASCO and saying, hey, do this proton CSI thing for my patient in the hospital. And so, with this real world data asks, does real world experience reflect the exceptional MSK trial results? And then can we start to get a look at the question of does modern IMRT CSI, work just as well as proton CSI, which obviously is a big deal because we still don't have that many proton centers to do this. The proton treatment takes 45 minutes sometimes to an hour, and at least at our center I have to fight and claw to try to get access before the 2-3 week wait time for our proton center that's treating till midnight every day to get these patients on, and there's a real access issue. And so it would really be a great thing for the field if we can further confirm that IMRT CSI may have the same benefits as proton CSI. And so here's a summary of real world data for trials for CSI for LMD that have come out over the last few years after the trial. And you can see that some of them, these groups from MD Anderson and Miami Baptist, had excellent results with survival, getting to a year or better, really reproducing the results by Yang et al. And others, here from our group, so this is the Mayo group, having survival more like 3 months. Or the group from MGH here, survival just of 4 months in these patients. And I'll talk a little bit more about this. I don't think it's because, I hope that the folks here at Mayo or at MGH don't know how to do CSI well. I think it's really a patient selection issue, seeing these major differences in overall survival between series. So this was our initial experience, kind of the first patients we treated with CSI after the publication of the MSK group. Many of these patients were hospitalized again, had been through all systemic options. We treated with proton or photon CSI. There was a shorter time to treatment with IMRT compared to protons. Overall survival was not better with protons. It was pretty limited either way, 3 months versus 1.7 months. There was no difference in grade 3 toxicity between the proton or photon arms. There was a little bit more lymphopenia and thrombocytopenia with IMRT, which makes sense, based on the anterior dose, but again, no significant differences in toxicity. And so with this, we have this question where there's the promising MSK results that look great for proton CSI, where there's some real world data that shows, maybe that, this isn't as much of a magic bullet and it doesn't improve outcomes as much. It's hard to say. And so what do we need to answer this? We need a large clinical trial across different institutions that compares proton CSI versus involved field radiation for these patients to try to definitively answer this question that, and this trial is being led by Jonathan Yang. I think this is a huge deal to know, is it helpful to do CSI for these patients, proton CSI or VMAT? If yes, that's great. We should start doing it as much as we can. Or if not, it's a huge burden on patients and systems to do this CSI. We should know, that it's not, to not do this to patients towards the end of their life and some of their few remaining days. The answer is likely that it benefits some and it doesn't benefit others. and hopefully, with the CSF markers, cfDNA, circulating tumor cells, we can better predict who it will work best for. But I think this trial is a really important first step. So this trial, again, newly diagnosed non-small cell or breast cancer, LMD. They have a KPS of at least 60. They're doing okay. They have, there's some limitations on the prior spinal cord or cotta equina dose. They need to get an MRI. You need to get approval for proton CSI. And then they're kind of stratified by these important factors, whether they have systemic disease, what the histology was, and randomized between involved fields, so whole brain and focal treatment, versus proton CSI. The statistics here, looking for a pretty major difference in overall survival, 71% versus 50%. I think it's appropriate to be ambitious with this. If this is going to be worth doing and you're going to put all the resources and effort and patient burden into doing this, it really should be a significant difference. So I, commend the ambitious and bold design here. It's going to be 104 total patients. As of this morning, when we enrolled this patient I mentioned earlier, I think it's at 31 patients now out of 104. So before we have the results of BN014, what do? I think this is a figure made by Rupesh Kateka that's a really nice kind of schema for how to do this in clinical practice right now before we have a trial. And first of all, you diagnose the patient by getting the full neuroaxis MRI and CSF evaluation. And then you risk stratify them. Patients who have better life expectancy, less neurologic symptoms, better controlled extra CNS disease, including remaining systemic therapy options, and then the ability to tolerate radiation, those are good risk patients. It's really just these patients that we should potentially be considering CSI for. Those who don't have the capability or the prognosis to potentially go through these treatments, these people who might have fit on the Quartz trial historically, may do best with just palliative focal treatments, steroids, and potentially hospice. And so, maybe some of the patients that were treated on our early experience and others would have fit better in this category than this one. Whereas, again, your patients with better risk may be good candidates for CSI or for systemic therapies, CSF therapies. Contouring for the CSI, I'll go quickly here as I run out of time. The CTV includes the brain and the spinal canal, of course. We often start this by doing a 1 to 2 millimeter expansion from the brain itself so that you're getting the inner table of the bone on the skull to really cover the entire leptomeningeal space. You'll cover the whole cribriform plate, pituitary fossa, and then along the cranial nerves here that have some CSI in the nerve sheaths here. And so, along the IACs, along the foramen ovale, foramen rotundum, to make sure you're getting coverage here of all the CSF, and then you cover inferiorly down to S3 or the bottom of the cotta, whichever one is lower, and it's okay to contour generously there. For proton CSI planning, we'll often use 4 or 5 fields, this kind of tipped anterior beam here, as well as, in this case, 4 posterior spinal fields. The fields are reduced by 1% per millimeter for the bottom 100 millimeters or 10 centimeters of each field, and the top 10 centimeters of each field to kind of smoothly feather these fields together, and they're robustly optimized together. And then we match, really tight to the cribriform plate, and then try to get to 3 millimeters to the spine. For VMAT planning, we use at least 3 isocenters, 1 for the brain, and then at least 2 for the spine, using partial arcs for the spine with partial posterior arcs. All isocenters are optimized simultaneously, but we'll evaluate each of the fields separately. And again, put 8 to 12 centimeter overlap between fields so that you can feather them smoothly. And looking for that smooth 45-degree dose profile from one field to the next at the gradients to make sure you're safely treating between fields. So again, back to our case to wrap up here. This patient on her planning scan for SRS unfortunately was found to have LMD. What do we do next? We need a spine MRI. We don't need a lumbar puncture, but we're going to get one to potentially get some of those useful diagnostic and potentially prognostic and predictive markers. We're getting those MRIs. In terms of treatment, we're talking with multidisciplinary colleagues about EGFR-directed therapies, as well as the neuro-oncology folks who we're fortunate to have those, maybe neurologists at some center. who really do great neurologic exams and can sometimes talk about the intrathecal options, and risk stratify to determine management options. And ultimately, this patient is enrolling on NRG BN014. So key takeaways here. Leptomeningeal metastases are associated with significant morbidity and limited survival. We need to learn to keep doing better here. Phase 2 institutional data from Memorial Sloan Kettering indicates a potential advantage to proton CSI for PFS and even survival over standard whole brain radiation, and this makes sense intuitively by covering the whole space. Proton or VMAT CSI allow for safer coverage of the entire CSF space compared to older techniques, and NRG BN014 will better define the value of CSI for LMD. So here are my kids this morning. Thank you guys very much for the opportunity to speak, and I'll look forward to talking more in the panel discussion.
It's a great talk, Will. Great costumes. Thank you so much. Yeah, I guess we glossed over that part that it was Halloween today. So happy Halloween to everyone on the call. I certainly have questions for you. I'm hopeful that everyone is going to take advantage of the chat function. Lower right-hand corner of your screen. Please feel free to post questions to all of our presenters this morning. Would be a great opportunity to engage everyone in that panel discussion. We're going to move on to our next panelist. It's just an absolute pleasure to introduce Jessica Wilcox. She's an attending physician at the Department of Neurology, or in the Department of Neurology at Memorial Sloan Kettering in New York. She's a board-certified neurologist and neuro-oncologist whose clinical and research focuses on brain and leptomeningeal metastases. Her work integrates clinical care, translational research, and clinical trials aimed at improving outcomes for patients with central nervous system involvement from solid tumors. Really excited, again, as kind of a springboard even off of Dr. Breen's talk, to hear from her at a talk entitled Leptomeningeal Metastases, Emerging Concepts and Therapeutic Opportunities. So warm welcome to Dr. Wilcox. Thank you so much for joining us this morning.
Hi, thank you so much for the kind introduction and for inviting me to speak with you all today. Happy Halloween. I regret that I don't have a picture of my son to post. He's a puppy this year. But I'm really excited to talk to you all about leptomeningeal metastases today. And just to review, we're going to talk about some, crash course through the function and anatomic considerations of the intrathecal space, the microenvironment of the CSF, with and without leptomeningeal metastases, some ways in which we think cancer cells gain access and survive within this hostile environment. And then most of the talk will be spent talking about emerging treatments for leptomeningeal metastases. So I think I don't need to impress upon all of you the critical functions of the cerebral spinal fluid. It helps with hydromechanical protection of the central nervous system. It's an important medium for nutrient exchange and waste removal. And specifically for cancer cell patients, it's important for management of intracranial pressure and immune surveillance within the central nervous system. As a reminder, the leptomeninges comprise the pia and arachnoid matter, and CSF is constantly being produced within the central nervous system and turned over about 3 to 5 times per day. Spinal fluid is created by the choroid plexus, which are these tiny little organs within the central nervous system that have a very distinct blood CSF barrier that is different from the better known blood-brain barrier. And so because of that process and because of those anatomic considerations, drug penetration through the blood CSF barrier is thought to be different from drug penetration through the blood-brain barrier. And that's important to consider when you're thinking about systemic therapy treatment options for these patients, and not to just assume that drug won't get into the spinal fluid. Typically the cerebral spinal fluid is a relatively quasi-immune location with a few circulating, primarily monocytes, macrophages, and some T and B cells within the cerebral spinal fluid. However, in the presence of cancer, we see a very large immune infiltrate into the CSF. And so you can see up here, I don't know if you're able to see my mouse, but in green, in green you see some immune cells, and in red, and then here in Orange and yellow are the cancer cells. So this is collected from pooled spinal fluid of 5 patients, and you can see that the immune cells actually far outnumber the cells of cancer within the CSF. And when you compare spinal fluid versus arterial blood, you can see that the spinal fluid is a much lower concentration of these critical micronutrients, including oxygen and glucose, amino acids, and iron, which is something that I'll get to at the end of this talk as it relates to a clinical trial that we're running at MSK right now. So it really speaks to this being a very diverse and nutrient sparse microenvironment. So because of that, why do cancer cells penetrate and survive within this space? We have a few ideas for why that might be. One is that the choroid plexus holds these complement receptors, and cancer cells secrete complement, which bind to those receptors and allow nutrients to penetrate into the CSF compartment. So in the presence of cancer, they'll actually pull their own nutrients into the CSF so that they can use that to grow and divide. We know that cancer cells also use an iron scavenging system called lipocalin-2 and Slic22A17. The cancer cells will compete with macrophages within the CSF for free iron to support their metabolic needs. And last but not least, the immune microenvironment within the spinal fluid is mostly comprised of exhausted and anergic T lymphocytes, and those cells have reduced cytotoxicity potential, which is a reason why we think that these cancer cells just don't respond quite as well to intravenous immune checkpoint inhibition, as I'll share in a couple of slides. So, again, I don't think I need to impress upon all of you the very wide-ranging set of symptoms that can be associated with leptomeningeal metastases, both due to cancer cell deposition on the nerves causing them to misfunction, for example, cranial neuropathies and radicular pain and bowel and bladder dysfunction, but also due to increases in intracranial pressure, which are also often associated with diplopia and headaches and papilledema and nausea and classically unprovoked emesis. And so when staging and evaluating somebody with newly diagnosed leptomeningeal metastases, I agree wholeheartedly with Dr. Breen in doing neuraxial imaging with MRI brain and total spine with and without contrast, because you really need to see at baseline all the areas that the leptomeningeal metastases are touching, so that you can use that to serve as a baseline and also to monitor with responses to therapy. And I also strongly recommend a lumbar puncture. I think a lot of times we're fairly confident in the diagnosis of leptomeningeal metastases on imaging alone. However, we do see quite a few mimics of leptomeningeal metastases, which can be the case with some indolent meningitic infectious processes like Cryptococcus I diagnosed 2 months ago in a patient who was originally thought to have leptomeningeal metastases. Also, in the era of immune checkpoint inhibition, we will sometimes see an aseptic meningitis without leptomeningeal metastases, which similarly looks like leptomeningeal enhancement, and particularly in the cauda equina. And so I wouldn't just assume that all that is enhancing within the leptomeninges is cancer, and of course is treated very differently. Also, I think it's important to get a sense of what their intracranial pressure is at baseline, because these symptoms can be a little bit nebulous with, headaches that are not always positional, and nausea and neck pain. And it might not be overtly obvious at the onset that these patients have high intracranial pressure, but it's critically important to know that, because that influences what leptomeningeal directed therapies that they would be best candidates for. And I think, unfortunately, the gold standard for the diagnosis of leptomeningeal metastases, which is CSF cytology, has a relatively low sensitivity of only about 70% with your first lumbar puncture, which is why classically people or physicians are recommended to do 2, sometimes even 3 lumbar punctures if your suspicion is high and the first LP is negative. But there are emerging cancer cell assays and circulating tumor cells that are much more sensitive for diagnosing leptomeningeal metastases. And there's a few commercial assays that are available and also some institutional assays. And so, for example, at MSK, we use the EpCAM-based cell surge circulating tumor cell assay, which has a sensitivity closer to 93%. So when these assays are available to you, I encourage that you use them, particularly if it's a low volume of leptomeningeal enhancement and you suspect that you're going to need a more sensitive assay in order to diagnose it. So in the setting of increased intracranial pressure, we often recommend ventriculoperitoneal shunts just as a means of providing palliative benefit to these patients. It relieves intracranial pressure symptoms in 70 to 80% of patients. And there was a retrospective review done at MSK that showed a median survival of only 2 to 4 months from the time of shunt placement. However, much of that was driven by patients with a very large burden of leptomeningeal metastases, and there was at least 25% of the patients in this study that had much longer term survival after the shunt was placed. And so a shunt is a means to sometimes allow patients to continue with proton CSI or further tumor-directed therapy. So, just to reiterate what Dr. Breen had reviewed with respect to dividing patients into good risk versus poor risk, based off of their functional status and status of their extracranial disease, and considering how to best treat these patients. I like this slide because, anytime you hear leptomeningeal metastases, it's like you automatically regurgitate a historical survival of 3 to 4 months. It's what everybody says over and over and over again. And I really don't believe that that is the case for everybody anymore. I think the historical survival was driven by some of these very early clinical trials of whole brain radiation therapy and intrathecal therapies that were developed in the 1980s and 1990s at a time where MRIs were just coming onto the map, and we didn't have such sensitive diagnostic tools for these patients, and we didn't have really any of the modern cancer-directed therapies that we have today. And so, when you look in the last decade, you can see that some of these clinical trials are showing all these numbers are overall survival from prospective studies, fairly better overall survival in select patients. So, of course, a lot of that is being driven by patient selection and availability for some of these highly CNS and CSF penetrant systemic therapies. But I really, every time I'm meeting a new patient with leptomeningeal metastases, I always will adjust my prognostic predictions on the basis of everything about them, not just, what is historically represented in the literature. So Dr. Breen gave a wonderful overview of radiation therapy for leptomeningeal metastases. So I won't linger on these next 2 or 3 slides, but just to say that I think that radiation is a very powerful potential treatment for these patients. That it helps to treat bulky nodular disease and palliate symptoms. But very importantly, the conventional IFRT and whole brain radiation therapy or focal spinal radiation has never been proven to improve survival in these patients. So the reason why is, obvious when you think about it. If there's cancer's cells that are floating up and down the neuroaxis and you only radiate the cancer cells that are adherent to the surface of the brain and spinal cord that you can see, you're essentially leaving all those floating cells untreated. And so when I'll skip over this slide looking at outcomes for proton CSI versus IFRT, since Dr. Breen just went over it, but this is looking at change in circulating tumor cell enumeration in the spinal fluid before and after these therapies. And in red are the lines for patients that received IFRT, and in blue are for patients that got proton CSI. And so you can see at time 0, when radiation was administered and following over the following 12 months, patients that got proton CSI, you saw a reduction in circulating tumor cell numbers over time in the spinal fluid, versus in red, they only went up. And so the most important consideration for proton CSI and when to offer it is patient selection. It's a very powerful treatment, but it can also be very toxic, particularly in somebody who has a poor functional status at baseline. And so, I know that, a very wide array of survival estimates across different institutions. And I think a lot of that has to do with the patients that are being selected to receive these treatments, and amongst other things. But I generally, in my practice, I only recommend it to patients that have a KPS of about 70 or higher, and in the younger age group, because another thing that I think wasn't mentioned before, but what we see anecdotally in clinical practice is that not only does proton CSI become harder to tolerate with increasing neurologic clinical burden, but also as you get older. Patients over the age of 70 also, often have a harder time getting through therapy, and can have pretty debilitating fatigue that persists after radiation's been delivered. So to transition now over to some intrathecal therapies for leptomeningeal metastases, which is, I think, where neuro-oncology really shines. Just to review, we prefer to give intrathecal therapies to patients with Ommaya reservoirs. There's been some studies that have shown that intrathecal therapy through an Ommaya leads to better survival and outcomes compared to intrathecal therapy through lumbar puncture. And it provides very convenient, reliable access to the spinal fluid. It provides more comfort for patients so they don't have to do routine lumbar punctures. But there are some small risks, including perioperative risks of hemorrhage, infection, or shunt malfunction. And in between 1% and 10% of patients, patients can develop iatrogenic bacterial meningitis due to frequent puncture of the skin floor, even though we do this under sterile conditions. And most importantly, for when considering who might be a good candidate for intrathecal therapy, is to ensure that they don't have elevated intracranial pressure. Because when you administer drug into the spinal fluid in somebody with altered pressure and CSF flow dynamics, the thought is that the drug just doesn't circulate well, and it puts the patients at risk of developing a ventriculitis and increased ICP symptoms. So much like proton CSI, I think with intrathecal therapies, there's also a relatively narrow window for when patients can receive these drugs. And so I caution you all not to wait, when you're considering these therapies, if you seems like your patient would be a good candidate for them. Intrathecal therapy, the frequency of which it's administered depends on the drug, but most drugs, such as methotrexate and topotecan, are administered at a frequency of 2 times a week for about 4 to 6 weeks, ideally looking first to see clearance of the CSF cancer cells and cytology. That's your induction phase, and then you transition to a consolidation and maintenance phase where you do treatment then once a week for approximately 4 weeks, and then once every 2 to 4 weeks until you see leptomeningeal metastasis progression. In our institution, we generally recommend the lab parameters of platelets over 50,000 and absolute neutrophil count over 1,000 for safety of drug administration. And I often give my patients dexamethasone to take orally on the day of and the day after treatment to help with some of the symptoms associated with chemical meningitis. So these patients will often experience mild headaches and nausea at the time of drug administration. That gets better after the next 1 or 2 days. There's a wide range of survivals that have been reported because some of these drugs, again, had been studied initially in the 1980s and 1990s, but in general, my experience is that these drugs tend to, for patients that they do work for in the spinal fluid, they will work for approximately 5 to 6 months, sometimes even longer. And in addition to methotrexate and topotecan, which are standard of care options that are available to anyone, and not really cancer specific, they're relatively agnostic in terms of what cancers will respond to them. There was also Depocyte or liposomal cytarabine, which is not on the market anymore due to manufacturing issues. which had shown some pretty good survival outcomes in the last couple of years, studied by Emily Laroon out in Europe. Trastuzumab has been shown to have median survival of 7 to 12 months in patients with HER2 positive disease in the CSF. And then pemetrexed has been studied for patients primarily with EGFR mutant lung cancer that have progressed after EGFR targeting therapies, and is something that I've used from time to time. And one thing that I want to comment on is that methotrexate, particularly when combined with whole brain radiation therapy or shortly before or after, can be associated with a really profound leukoencephalopathy. And so for that reason, it's actually not my first choice. I prefer topotecan for my patients, especially if you think that whole brain radiation therapy is going to be in their future, because I just find that it has a lower incidence of causing neurocognitive dysfunction and leukoencephalopathy. And I've also seen a fair amount of leukoencephalopathy with pemetrexed, which is not surprising as it's similar in action to methotrexate, but just something to consider when you're trying to select which drug to use for your patients. Now, in terms of systemic therapies for patients with leptomeningeal disease, it's usually not the first-line therapy for these patients, with the exception of EGFR mutant lung cancer, which has a nice response to osimertinib. It's generally used in combination with radiation or intrathecal therapies, and I strongly support the change in systemic therapy to something that you think might have better CSF penetration, even when you're combining, treatments with radiation therapy for these patients, because, oftentimes we'll run into the situation of patient has isolated leptomeningeal metastasis development with stable extracranial disease, and you send them for proton CSI or radiation and then don't change the systemic therapy because it's still working for their extracranial disease. But, what I find in those circumstances is that, whatever was the driving force causing leptomeningeal seeding into the CSF, because most of the cancer cells we think get there by way of hematogenous supply, those patients will have progression sooner than if you were to potentially change their therapies. If they have something available that might have better CNS activity. So that's something just to consider as you're trying to fold systemic therapies into the management of treatment of leptomeningeal disease. And then there's the issue of not knowing the CSF penetrance of a lot of these agents. Unfortunately, pharmacokinetic studies in the CSF are few and far between, even in clinical trials that are looking at systemic therapies for leptomeningeal disease. And so, I highly encourage for patients or for people that are creating clinical trials in the space to try to include pharmacokinetic assays so that we can know how much drug is actually getting into that space. So, immune checkpoint inhibitors such as pembrolizumab and ipilimumab and nivolumab, these were studied for patients with leptomeningeal metastases up at Dana-Farber. There were 2 phase 2 studies, one with pembrolizumab in 20 patients. The predominant patient population in the study was breast cancer, and then ipilimumab and nivolumab in 18 patients. And the median survival for both of these studies was approximately 3 months. So not much better than the historical average, although these were heavily pretreated patients. And so, not all of them were newly diagnosed leptomeningeal metastases. Many of them were recurrent disease. And, when you look at the spinal fluid in these patients that were exposed to systemic immune checkpoint inhibitors, what you found was that while there was an increase in effector T cell and interferon gamma response signaling in the CSF shortly after drug was administered, it seemed to be short-lived. So when you look at, these markers pre-treatment and then both early and later in their systemic therapy courses, you'll see a small increase in effector T cell functioning, and then it falls back down to baseline values. And that might very well be part of the reason why these systemic therapies just don't have a very long and durable response in the CSF. Because remember, the CSF immune microenvironment is faulty and just doesn't behave like the rest of the systemic circulation. From this came the thought of, well, what if it's a penetration issue? There's been studies that have suggested that only 1 to 2% of systemically administered immune checkpoint inhibitors actually get into the CSF. So what if we put drug directly into the CSF? So this is a study that came out of MD Anderson with Dr. Glitza, looking at a combination of intrathecal and intravenous nivolumab in patients with melanoma, leptomeningeal metastases, and found a median survival in these patients of approximately 5 months. So, a little bit better than historical average. And then when you look at the patients that were treated on study, now in red is how long the patients were on treatment. And then the total duration, length of the bars is patient survival. And you can appreciate that, while a lot of these patients had fairly rapid progression within the first few weeks, there was a subset of patients that had longer term responses, including patients that have, and you see here in green, positive CSF at baseline. And so since the study was published, intrathecal nivolumab is now part of the NCCN guidelines as a 2B recommendation. And so it's available, at all institutions to use, but it's really only available for patients that have private insurance, because Medicare and Medicaid, as of right now, will not pay for it. Now transitioning to targeted therapies on leptomeningeal metastases, as I discussed before, Tagrisso is basically the poster child of a systemic therapy that works in the leptomeningeal space. So much so that in patients with newly diagnosed EGFR mutant lung cancer, particularly those that are Tagrisso naive, we often don't do radiation at the onset. We'll start with Tagrisso either at a dose of 80 milligrams or 160 milligrams, and often see really, really nice radiographic and cytologic responses in the leptomeninges. This was followed by a study looking at amivantamab and lazertinib in patients with EGFR mutant lung cancer at MSK, which enrolled patients into 2 cohorts, one brain metastasis and one lung metastasis cohort. Importantly, these were heavily pretreated patients, and all patients with leptomeningeal disease had either positive cytology or circulating tumor cells in the CSF. And you can actually see that patients with leptomeningeal metastases had a longer response than those with brain metastases. And so this is a very good treatment option, although it can be a little difficult to tolerate from a toxicity perspective. The HER2 CLIMB regimen of tucatinib, capecitabine, and trastuzumab has been studied in patients with leptomeningeal metastases. Unfortunately, the study closed early due to slow accrual, but these were patients that had a median survival of almost a year from the time of study onset. And so again, tucatinib has very good penetration into the CSF with a about approximately 80% of what the plasma concentrations are. And I talked a little bit already about intrathecal trastuzumab. I'm just going to glaze over this for the sake of time, but has also been associated with a nice long survival in patients with HER2 positive disease. And then in terms of antibody drug conjugates, we didn't really know until fairly recently whether these bulky molecules had any activity for the leptomeninges. We knew that in HER2 positive breast cancer, brain metastases had a really nice response to Enhertu, but we didn't know how, if that molecule penetrated into the CSF, if it really had any activity in that space until, 1 or 2 retrospective real world reviews, followed by the publication of the DEBRA study, which looked at patients with both HER2 positive and HER2 low leptomeningeal metastases, was published. And this was only 7 patients, in keeping with most leptomeningeal metastases trials are relatively small, but these patients all had cytology positive leptomeningeal metastases. They were all local therapy naive and had a median survival of 13 months and a median progression-free survival of 9 months, with virtually no patients coming off study due to intracranial progression. So And this is another one of those regimens that you can consider doing upfront in HER2 and reserving your local therapies like radiation and intrathecal therapies unless they need them for palliative reasons. And so just in my last 2 minutes, some emerging ideas for leptomeningeal disease. At MSK, we have a clinical trial here looking at intrathecal deferoxamine, which is an iron chelator in the treatment of leptomeningeal metastases. This all came from the work of Dr. Adrian Bohr, who's my colleague here, who has a lab that almost exclusively studies leptomeningeal disease and found that cancer in the spinal fluid relies on iron in order to grow and divide, and that when you treat mouse models of leptomeningeal metastases with an intracisternoid iron chelator, deferoxamine, you saw more difficult growth of the disease in the leptomeninges, as well as an improvement in mouse survival. So this led to the creation of a phase 1A and B clinical trial, first in human study of intrathecal deferoxamine in patients with leptomeningeal disease. We are through phase 1A. We already know what our maximally tolerated dose is, and we're now enrolling 20 patients with, at that target dose with any solid tumor leptomeningeal disease. So send us your patients. We have only 6 or 7 slots left. It's been pretty rapidly accruing. And then this is another really interesting study to highlight being done at Moffitt with Dr. Forsyth, looking at intrathecal dendritic cells in patients with HER2 positive and triple negative breast cancer and leptomeningeal disease, with the thought that these dendritic cells that are pulsed with HER2 and HER3 antigens will facilitate an adaptive long-term anti-tumorigenic immune response. And so I believe the first phase of this clinical trial is wrapping up, but there should be another phase 2 clinical study to follow shortly that I know Dr. Forsyth is currently working on. So, thank you everybody so much for having me. It was really my pleasure to speak to you today. If any questions come up regarding management of these patients, I'm always happy to provide you with any guidance or, provide second opinions, and just to refer you to this really beautiful consensus work that was done and published a year ago for a couple of, kind of thought leaders in the leptomeningeal metastasis field in terms of practice management and guidelines. Thank you.
Dr. Wilcox, thanks so much. That was just a wonderful talk. Appreciate you sharing that expertise, and just really happy with the progression of the last 3 talks, actually, with, looking at leptomeningeal disease with advanced diagnostics to radiation treatment to some of the, more neuro-oncology or medical oncology approaches to treating this disease process. That was really just a great succession of talks. So thanks for sharing your expertise. I appreciate you. So if we could ask all of the speakers for the morning to jump back on camera. As mentioned, I certainly have some questions for our panelists and wanted to pick their brain. Dr. Eisner, first of all, thank you so much for your great talk. I looked upon your work with treating multiple brain metastases, obviously with stereotactic radiation, is transformative, and I don't think we could scream it more loudly from the mountaintops to help with this transition. I've been doing this in my practice for a really long time, and sometimes to the shock of my medical oncology colleagues, that they're thinking that the patients are just going to be subjected to whole brain radiation therapy with, greater than 4 metastases and then greater than 10 metastases, and now you've pushed the pocket all the way to 20. So, I'm just curious though, in your own clinical practice, what fact, and I've written it here in the chat, specifically what factors like total tumor volume, histology, neurocognitive outcomes, and integration with systemic agents. And we've heard from Dr. Wilcox's talk, obviously there's a whole emerging appreciation of CNS penetrating drugs that can have a similar impact on this disease process. What should really guide our decision to continue offering focal stereotactic radiation rather than reverting to whole brain? And do you believe we're approaching a point where lesion count alone is no longer a meaningful threshold?
Yeah, I think it's a really, great question, Dr. Bovey, and very well stated. I think that As you mentioned, historically, it's been a lesion count issue, but obviously it's more complex than that, as you allude to. We're often, in fact, we don't spend a lot of time focusing on volume. The only way that volume factors into our personal decision making, although I know groups vary and people have published on this in different ways, is if we're treating so many metastases that the integral whole brain dose, just given as scatter, may be significant, because as we all know, we might be, if you treat 30 metastases and there's some bulky ones, you might be giving 8 grade times 1 whole brain with boost, essentially, so we want to avoid that, in which case we often either fractionate or break them up into different groups to treat one day or another. So volume has not been a major player for our group, at least, although I know groups vary. We focus a lot on brain met velocity, so although I think SRS is probably better for the typical patient with up to 20 brain mets. If there was one met a month ago and now there's 19, you do wonder that patient probably does need whole brain radiation. Conversely, if a patient had like 25 brain mets a month ago and now there's 26 or 27, we've generally felt pretty comfortable offering that patient SRS, even though they exceed sort of the boundaries of the literature. We're often debating, with systemic therapy, we're often debating which one to use. We generally in our group don't do both. So we tend not to switch systemic therapy and do radiation, although groups vary. We typically will do one or the other. And then it really just comes down to, are we dealing with a pressing situation where we need radiation? And also, what's the likelihood that we're going to see a systemic response in a given situation for a particular agent in a particular patient? So, as much as the data guides us, I agree with you. I mean, I think it's very, individualized in terms of how to best manage these patients, in the modern era.
Yeah, I agree with you 100%. And I think it just screams for the absolute need for multidisciplinary discussions in these patients for, how best to proceed. I had another question for Dr. Bedegato. Thank you so much for your talk. Given the challenges of obtaining tissue in patients with brain mets, which is sometimes a diagnostic challenge for all of us, particularly when lesions are small or multiple or in eloquent regions of brain, how do you see liquid biopsy evolving as a tool for diagnostic and longitudinal monitoring in these patients?
Yeah, thank you, Dr. Bovey. It's, I think, a really important area where liquid biopsy has opportunity to, I think, fairly dramatically influence our clinical decision-making, clinical care. I think, thankfully, these technologies are now in the commercial realm, and so people are using it to be able to identify whether a lesion on MRI is neoplastic or not, and furthermore stratify it based on genetic alterations to be able to understand if there are targeted therapies that are appropriate or other systemic approaches. And so indeed, I think that's probably, in my mind, the earliest sort of introduction and where the data are highest to be able to use liquid biopsy approaches. I think the idea of longitudinal monitoring is very provocative. Of course, I think the literature suggests that the most sensitive approaches are based on CSF sampling. And so the idea is, which patients would benefit from longitudinal LPs. Plasma testing can be helpful in the setting of metastatic disease, though plasma will also pick up systemic disease burden. So in individuals who have brain mets, there's of course often confounding systemic metastases, and there can be, as we're all aware, discordant responses. So the CNS may be behaving in one way where the systemic disease. And so I think beyond the sensitivity of the approaches, plasma also has this additional opportunity of informing us of what's happening in other organs that may be difficult to interpret if we're just focusing on what's happening in the brain or the CNS. And so I think both for diagnosis and longitudinal monitoring, it's really an exciting opportunity to use some of these more nascent technologies to inform our decisions.
Just taking that one step forward, I think as we learned from like last 3 LMD talks, that what we used to think as one LMD as a terminal event is really a spectrum of disease. Not everybody has that dismal survival. And I think what your talk really said, that maybe we can take that from a dismal disease to bring it early diagnosis and treat early before it becomes very problematic. Uh, uh, so I want to ask, like, where do you see the role of maybe having a continuous access to CSF, in terms of having an Ommaya placed in? So we are actually seeing, as Dr. Wilcox mentioned, the need for monitoring of how our treatment's doing. Where do you think that is going, and do we go there?
Yeah, no, thank you, Dr. Day. It's a great question. I think you're right. I think there's a new light being shown on leptomeningeal disease, and we shouldn't assume that the prognosis is so abysmal that we need to just think about palliation, not just for LMD, but also other parenchymal mets and even primary tumors. And so at Hopkins, our practice is right now in clinical trial setting, in fact, to place Ommaya reservoirs. I think there are a number of centers, perhaps some represented on the panel today, where there's a spectrum of where we're willing to put in the Ommayas. I think the relative risk, and you know this very well as a talented neurosurgeon, for placing these for patients is relatively modest. And I think if we can say, hey, gosh, look, we're going to be able to molecularly follow what's happening with your cancer. We're going to be able to understand resistance, progression, new vulnerabilities, the immune microenvironment, all these added benefits. Is that sufficient to warrant, a small procedure and some small risk associated with that? I think that certainly for us, when we're thinking about clinical trials in the brain metastasis space, that's a very common concept that we're putting forward. Our patients have not pushed back on that. Our IRBs have not pushed back on that. So I think right now at Hopkins, we're doing the clinical research space. I see it very quickly transitioning as we get more data of potential benefit to patients to be introduced as a discussion incorporating standard of care decision making. Yeah, absolutely.
I have a follow-up question to that, and it kind of crosses between your talk and Dr. Wilcox's talk. So it makes me think about sort of the role of ventricular peritoneal shunting in patients with leptomeningeal disease and versus and/or an Ommaya. And so my question was first for Dr. Wilcox was, we commonly place VP shunts, like you said, because we had sort of similar observations to you. But the sort of classical concern is for seeding the peritoneum. And I'm wondering if how often you guys actually see that in practice. It's well reported, and I think I can think of maybe one case I've seen in my career. But and then my other question for Dr. Bedagawa is, does a VP shunt help or hurt access to the CSF in terms of sampling? Because on the one hand, it gives you the reservoir, but on the other hand, you're constantly sort of draining that reservoir.
Yeah, so your point about the risk for peritoneal seeding is a well taken one, and something that patients often ask me too right off the bat. It makes logical sense to think that if you put a shunt draining into the peritoneum, that could provide a highway for cancer cells to get into that space. But in truth, it's just not something that we frequently see. I've seen some mostly retrospective studies reporting a risk of this up to about 3%, 3 to 5%. So it's not considerably high, particularly when you think about a lot of these patients all have also advanced extracranial disease. And so, many of them might already have peritoneal seeding, but, we don't consider that as a shunt prohibitive risk, particularly because a lot of the times these patients need them if they're going to continue with any tumor-directed therapy.
Yeah, no, great question. For us, accessing the VP shunt, we feel very comfortable with that. There is the small risk of an infection when we do tap them, but we certainly, when we've placed it for folks who have metastatic cancers of the brain, we've used it frequently to assess everything from intracranial pressure to infection to cytology to liquid biopsy. And so I think it has been a valuable tool. We do think a little more seriously about that versus just a simple Ommaya. But I think our experience has been that it is a very safe access device even when it's connected to the peritoneum. And knock on wood, we haven't seen adverse events associated with sampling the CSF from that space.
Does it affect your diagnostic yield, either the sensitivity or?
Yeah, so I think that the literature is a little mixed. There's certain assays that will report that the closer and more proximal the CSF is sampled, the higher the sensitivity of these liquid biopsy assays. And so, highest being juxtaposed to the tumor at surgery, of course, that's not something we can do daily, followed by a ventricular catheter, followed by a lumbar puncture. Our data from our patients at Hopkins suggests that we don't see as much of a difference between a lumbar obtained CSF versus an intracranial or ventricular CSF sample. But I think when we look at the literature broadly, definitely there are reports that suggest that the more close the CSF sample is to the tumor of tumor location, the higher the yield of tumor-derived material and the increased sensitivity. But for us, Omaya versus VP Sean, we certainly haven't seen any difference there.
I had one question for you, Will, as well. Actually, before I do that, it looks like we got one from the audience. Let me take that first. Thank you, Dr. Iser, for an excellent overview. I really appreciated how you highlighted the evolving role of multi-lesion SRS. In patients who've received large volume or multi-lesion SRS, it's not unusual to see small radiographically suspicious foci on follow-up MRI, especially when the brain has already been extensively irradiated. In these situations, do you think it's better to wait with short interval imaging to empirically wait with short interval imaging to empirically reirradiate, or to confirm with molecular tools like CSF or plasma circulating DNA for deciding on further treatment?
Yeah, I think it's a great point. And certainly when people have had a fair amount of SRS, there can be necrosis risk. And, it's not always one tumor that was radiated that, just gets bigger and causes necrosis. It can be a field effect sometimes where you see speckles of enhancement either in or abutting the radiation field. And that can be difficult to delineate from true tumor progression. So I think what we generally would say is that whenever there's doubt, for any reason, and we're dealing with relatively small lesions, we will, give it a scan or two and let them declare themselves. That being said, when there isn't doubt and we're going to use radiation, we do like to use it early, because the risk-benefit ratio is just very much in the favor of treating small lesions versus big ones. It's more effective and less toxic to treat a small site than a large site. So I agree. Whenever there's doubt, we give it time. But, if we feel pretty confident, and it's often patient-specific in terms of, what their history is and what we're seeing. But, then if there isn't much doubt, then we do like the early radiation if we're not going to be going a systemic route.
I agree with that 100%. Sorry, go ahead, Mahua.
One just follow-up question on that. I know you showed the data that the need for re-radiation is not any different, but what about like treatment like steroids or Avastin? When you're treating this many lesions, are you seeing more symptoms or more edema around it and the need for like medical treatment for these?
Yeah, that's a great point. We did look at time to steroid initiation. So among people who are not on steroids at enrollment, was it more likely in one group or another that they would get a prescription for steroids? And we plan to quantify it longitudinally beyond that. But based on time to event of first steroid course, there was no difference between arms. We did not look at Avastin. I do believe that, we will see more Avastin utilization in the SRS arm. I would point out, though, that we don't always, as many people do, go to Avastin as a first-line therapy per se. So, although we'll probably see numerically larger numbers, will they be clinically meaningful? I'm not sure. But your point is certainly well taken. That with longer follow-up of these patients and more necrosis, will our thinking change a little bit about, the upfront management. And again, I think the more that we can be doing to sort of minimize that necrosis risk, obviously the better.
I have a question for Dr. Breen. I really appreciate your talk on leptomeningeal disease and the role of proton CSI. But as you alluded to, that is a process that takes a lot of planning time. And these are patients that even with a good performance status quickly can deteriorate, I think. From a practical standpoint, what have you found successful in sort of implementing this program and sort of speeding up the process, or any tips and tricks for those centers that might be considering this either with VMAT or with proton-based therapies?
Brett, that's a great question, and that's kind of still a problem we're facing. I think there's multiple different steps that can take a while, and some of them, just getting access is a challenge for each center to face. In my biased opinion, people with LMD should have access to protons before prostates should, and things like that. And so I think they should be prioritized. But the in terms of the process of the things we can really control, I think one, your team does more CSI, the planning becomes faster, and you have kind of set beam arrangements and set planning that goes faster. We all have more auto contouring tools. I think that helps. I think with CSI, you don't have to go as crazy contouring every, the small bowel and the duodenum and the large bowel and all that, because it's, if you're using DLAs, I think there's a lot of shortcuts to go quicker with it, but it is absolutely an involved process. And so I think like having exactly that, having a intentional process for these and people who do them and how you're going to fit them in works much better than it just being a 5-alarm fire every time one comes through and you have to send 20 emails. And so I don't know that there's one definite answer, but I think getting in lots of reps and having a process is what helps.
Well, and I know we're cutting a little bit into our break time, but have just really enjoyed the discussion. And it's Dr. Day and my conference, so we can kind of do whatever we want. So we're going to break into that break just a little bit. Will, just one last question for you. I struggle with that randomized trial data with regard to involved field radiation compared to CSI. I don't think any of us were really shocked by that outcome. At least I wasn't shocked by that outcome. So a couple things that were a benefit for that. Obviously, I mean, it's fantastic that we're finally including leptomeningeal patients in any clinical trials, right? Whether that be for medical intervention versus radiation intervention. I think this is where we need to go. Purposefully excluding them from other trials, I think, was a disservice to a patient population that we're clearly seeing the needle move with regard to positive survival outcomes in folks who are treated in an aggressive way when they are appropriately selected. But help me out with your understanding, because I do CSI, I do involved field. I'm just curious from your perspective where you balance the decision-making points for each of those two approaches, seeing as one is clearly endorsed by NCCN, and then the other is, kind of considered experimental, perhaps inappropriately so.
Yeah, no, thanks for the really good question. I think that's kind of exactly the state of the science right now is that question. And so when the MSK data first came out, as I kind of mentioned, we were all so excited about it to see the survival benefit. I think many of us expected CNS PFS, but OS, that's great. And I think at that time, if NRG BN014 would have opened then, we would have had a hard time having equipoise and randomizing patients between CSI and involved field, just because it seems like one is way better. I wouldn't want my family member to get this arm of a trial. Our initial experience kind of doing CSI on everybody, and we did see that, the outcomes weren't as great as the trial numbers, and those who are, not candidates probably don't benefit from it. And it is a lot more burden on the patient and the system to do CSI. And so I think that real world experience of more kind of tempered enthusiasm gave us real clinical equipoise to be able to participate in the trial and really randomize between. That being said, off of trial, for a patient with, say, melanoma or something who wouldn't be a trial candidate, basically, if they are good risk in the sense that they, have reasonable systemic options, maybe if they're younger, have better performance status, very often we would go to CSI. That would be the standard. I do less, whole brain used to be done all the time. I do it less than one time a month for brain mets or LMD combined now, and even less than that. It's just not it's not our favorite go-to treatment. I was going to have a Halloween metaphor where I talk about patient selection, but I don't think any human being should be compared to candy corn, and so I didn't do it. So it's terrible. But anyways, I think it does come down to patient selection, and it's really those who are in a just palliative kind of approach with you need to get to treatment quick and limited options where we consider whole brain.
Beautiful. All right, what an amazing morning session. Thank you, everyone. We are going to take about a maybe 6-minute break, bio break, coffee break. We will reconvene afterwards to our amazing first morning group. Many thanks. This was just a great discussion, and it's great to see where the cutting edge treatment recommendations for patients with brain and spine metastases is going to. So sincere thank you, and we'll see you back in a little bit.
So it's my pleasure to introduce Dr. Steve Brownstein from UCSF, a creative force in academic radiation oncology whose work has bridges innovation, translational science, and patient-centered care. Dr. Brownstein has been a true thought leader in reintroducing brachytherapy and gamma-tile therapy for select brain metastases, emphasizing durable local control and quality of life for patients. He leads with a collaborative spirit and an ability to translate complex technology into meaningful clinical impact. Today, he'll be speaking on the role of brachytherapy, gamma-tile, in the management of brain metastases, and we look forward to hearing his talk.
Extensive thanks to yourself and the organizers for inviting me and just talking about the fact that I have done consulting for gamma-tile in the past, but I'll be talking about indicated employments of the technology. So over the next few minutes, I'll talk about the evolving radiation approaches for brain metastases, really in conjunction with the great talks you heard this morning, talking about some of the challenges with current therapies with a focus on the role of brain-directed brachytherapy and some future directions. So historically, now going back to the mid-20th century, radiation has always had a role in management of metastatic brain disease. I mean, this is even in the pre-CT, pre-MRI era. It was recognized that radiation therapy, frankly, of lower energies that we use today, was able to access essentially any compartment of the cranium. So whereas there's limitations in terms of the important, valuable role of surgical resection, radiation was able to be employed in patients of various stages of metastatic brain disease, various performance statuses, albeit initially with some limited efficacy in patients really ultimately coming to demise in many ways due to neurologic causes and disease due to lack of control. I do want to make a few statements about the role of surgery as part of management of brain metastases because it is so critical. And really when we talk about brachytherapy, it goes hand in hand. It's in conjunction with surgery. So craniotomies and brachytherapy are really a joint procedure. So historically we recognize through 2 seminal studies from Roy Patchell et al. For patients with limited burden of disease, single brain metastases, surgery in conjunction with radiation appears to be superior in terms of limiting the recurrence at the site of the brain metastasis, as well as impacting overall survival. And so in some ways this might represent some of the initial descriptions of truly oligometastatic or limited burden metastatic disease, where surgery, in addition to comprehensive, in this case whole brain radiation therapy, improves outcomes. The flip view of that is, as compared to surgery alone for single brain metastases, the addition of radiation also has a benefit in terms of reducing recurrence at that site of resection, reducing the recurrence at a distant site, a new brain metastasis, and having an impact on overall survival. And so historically, we often think of radiation and surgery when it comes to intracranial disease when there's an indication for surgical intervention, often for either single, large, symptomatic patients who need a decompressive intervention or tissue diagnosis, that surgery in conjunction with radiation is generally considered the standard of care. Although now the sequencing and the tools that we have is changing. So whereas, as you've heard this morning, historically more comprehensive radiation approaches were used, with the development of stereotactic radiosurgery. Here shown is Dr. Lars Lexell, the creator of the gamma knife, again, mid-20th century. Since that time, radiosurgery to be able to focally ablatively treat limited numbers of brain metastases is able to be performed on a number of platforms, gamma knife, cyberknife, monolinear accelerators, and this has become increasingly our standard of practice. And so in some, the management of patients with brain metastases can include surgery as noted, increasingly less so comprehensive radiation therapy, whole brain radiation, although you heard about the role of CSI in the more extensive leptomeningeal disease setting being increasingly employed. Focal radiation such as radiosurgery, systemic therapies. You also heard how more CNS penetrant systemic therapies are having a role in management of intracranial disease. And in some cases, it's important to acknowledge that supportive care may be appropriate, and we certainly have evidence base to reinforce that in select patients. But common practice for most patients with a limited number and volume of brain metastases, now up to 20 metastases through Dr. Iser's seminal work, radiosurgery is often preferred, and the local control is very respectable in most cases with our current practice at 90% or higher, although that doesn't hold true for all lesions, and this is an opportunity for us. Also had been mentioned is the potential of toxicity related from radiosurgery. While it's a valuable tool for patient care, there are challenges in that patients following radiosurgery can have, on the continuum of imaging changes, adverse radiation effect, which can be transient, to frank radiation necrosis and brain injury, which requires various forms of intervention, which might be pharmacologic management in the form of steroids, in the form of bevacizumab, and in some cases, folks exploring other interventions such as boswellia. However, in some cases, surgical resection may be required, and this can be a significant morbid consequence of what is otherwise a very effective and safe non-invasive intervention. So it's important to respect our evidence and our understanding of radiation necrosis. So certainly from any neuro-oncologist, radiation oncologist who focuses on the brain, is that this is not necessarily an uncommon event, and really understanding, what are the risk factors that might lend themselves towards frank radiation necrosis are really important to guide the interventions that we're doing. As it came up in questions following the last session, how can we think about this and minimize this? And so we do have some fairly robust studies, many single multi-institutional retrospective analyses that define certain dose parameters, V10, V12, at least in single fraction radiosurgery. We have similar parameters for multi-session radiosurgery. Just understanding that for the most part, as the volume of the treatment increases and the dose increases, the risk of radiation injury intuitively also increases. And so many of us will use these types of parameters to try to minimize the risk. As I mentioned, sometimes these are just radiographic changes on imaging, and they can be transient, but we are more concerned about the permanent and symptomatic events that occur, especially since radiosurgery is frequently used as compared to other interventions, such as surgical interventions, when there are lesions in eloquent areas of the brain where any type of injury can really have devastating consequences. So we've studied this as well at UCSF. One of my mentors, Dr. Penny Sneed, had looked at this in over 2,000 lesions and really defining, again, the likelihood of radiation injury as a function of volume of target, but importantly, and intuitively, that prior radiation to the brain, whether it's more comprehensive whole brain radiation or radiosurgery to a lesion that ultimately progressed and had indication for retreatment, that is likely to be associated with the greatest risk of potential radiation injury. So another consideration, we're talking about radiosurgery and our current excellent rates of local control, is that patients are living longer, and we've seen that in a number of series. This is a great, I would say, loosely problem to have. It's a wonderful circumstance of likely what is a better multidisciplinary management of patients. But in patients that have been studied who've had brain metastases, looking at overall survival and try to prognosticate what are the features that help us to understand, in some cases, who might be the best candidate for radiosurgery, but really just to prognosticate overall their overall survival. We're seeing improvements over time in modern era, and this is again is due to, as was mentioned, like the better both intracranial, extracranial disease control, and certainly the ability for newer agents to have CNS penetrance to act on potential microscopic or macroscopic disease in the brain. But this is changing for many of us how we think about our practice. And I just give this case as an example. This is a patient, a relatively young woman who had metastatic breast cancer, HER2 positive, a solitary brain metastasis treated with radiosurgery. You can see the solitary precuneal lesion that I treated back in 2014 and then followed over many years, had excellent extracranial disease control. And then in 2018, 2019, appeared to have some imaging changes that were somewhat indistinct, but in the area of prior treatment associated with some edema. We gave steroids followed by bevacizumab with serial imaging and found some progression over time. And I will get back to this case in a moment. But what we're seeing is the potential for late changes, either potential treatment effect, but maybe late recurrences, which wasn't so much pertinent many years ago when the overall average survival of patients was somewhere between 1 to 1.5 years in the setting of brain metastases. So to summarize, from my perspective, some of the current challenges in management of brain metastases includes radio-resistant histologies that can be difficult to control even with ablative stereotactic techniques. We talked about the spectrum of what might be diffuse miliary metastases up through leptomeningeal disease and how we're addressing that now with some modern pharmacologic clinical trial and craniospinal radiation approaches. Large lesions also remains a challenge for us. Even whether resected or treated definitively with radiosurgery as a function of size, it's more challenging to control these lesions with the dose strategies that we have, and also to do it in a way that preserves the therapeutic window and doesn't put patients at risk for excessive radiation injury potential. In the postoperative setting, so for patients still undergo surgery routinely for brain metastases, there is that risk of recurrence treating some of these larger surgical cavities, and also the risk of leptomeningeal due to potential instrumentation and microscopic seeding along the dura or the resection window. There's challenges in terms of recurrent disease, as I noted, in post-brain directed radiotherapy, how to approach that and do that safely and thoughtfully. We have many challenges distinguishing recurrence from adverse radiation effect, which is linked to whether or not we need to intervene with additional treatment. And then a challenge, which is a good challenge to have, is how do we integrate our current radiation approaches and surgical approaches with CNS penetrant therapies? Where can we defer radiation potentially? Where can we potentially dose de-intensify? But thinking about the sequencing and timing is something that is in the forefront of many folks' minds. And so with regard to some of these in particular, I hope to show you how brachytherapy may allow us to have additional approaches that could address some of these challenges. So as a radiotherapy modality, I think many folks are very, very familiar with external beam radiation therapy, which has really defined our approaches. The other formal name for that is teletherapy, giving radiation from a distance, usually using either source-based, but more commonly electricity-based linear accelerators to deliver radiation. And the vast majority of radiation given in the past century has really been with external beam or teletherapy. But brachytherapy has very strong historical roots and was some of the initial implementations of radiation as a therapeutic modality back at the turn of the 19th century. And it's commonly employed, not so much in the brain historically, but more so in the management of GU and gynecologic malignancies, and used today, either with permanent implants, which I'll describe, or temporary implants. And the potential benefit is that it gives a very high dose over a fixed period of time as a function of the source. And so it's using internal radiation is essentially the definition of brachytherapy, where you have a radioactive source that can be a naturally occurring or synthesized isotope, and I show some examples of that here. Palladium, iodine, cesium, iridium, gold, radium. And you can see that in all these cases, these radioactive isotopes, these nuclides, will emit energies of different types. All of these that I showed here happen to emit gamma energies, and they have a different half-life, and they can be generated with different activities and inserted again, either permanently or temporarily into a surgical bed, a cavity, an organ, to be able to deliver radiation over some time. And you can see the half-lives differ dramatically. There are 226 radium sources have a half-life of 1,600 years that in many radiation departments throughout the country are sitting in source rooms very, very slowly decaying, and will be decaying long since we solve all the problems and challenges in intracranial metastatic disease. So as a radiation therapy, it's important to distinguish this from external beam radiation therapies and radiosurgery, frankly. So most radiation treatments are delivered over the course of minutes for each session. It might be fractionated over the course of days or several weeks. But brachytherapy you see as a function of the half-life when a source is implanted into a tissue, such as the brain, for example. There are many factors that influence how it deposits dose, and what we call the biologic effective dose, and it includes the initial source activity, the dose rate, the decay rate, some intrinsic function of the geometry of how these sources are implanted, how tissues are responding to this and repairing, and even certain characteristics of the intrinsic response, something we call the alpha beta of the tissues themselves. So all of this creates a very sort of sophisticated, nuanced dosing approach, which is radiobiologically distinct from much of what we do with external beam and radiosurgery approaches. So I should note that there is historical use of brachytherapy for CNS tumors at the time of resection using older sources. So radon, which is a gas derived from radium that was placed within needles, has been used. One of the first reports was back in the 1930s in the UK, using this to treat pituitary adenomas. And at the time, this was being used in other settings to treat skin cancers and, again, gynecologic cancers. But I think, reflecting on the history, this is something that has been recognized as having potential utility, although understanding exactly how to implement that took some time. And so Harvey Cushing had used this to treat, in the primary brain tumor setting, gliomas, and implanting these radon sources throughout very large surgical cavities for just a few days to allow them to decay and give activity. Interestingly, to doses that we often use today, the cumulative doses that were in the range of, say, 40 to 70 gray, given over a few days. And as was the case with many of these initial employments of brachytherapy, they're associated with a fair amount of radiation injury and necrosis because the dose was so high. Historically at UCSF, these are some of my predecessors here within our Department of Neurosurgery and Radiation Oncology. We're using radioactive iodine sources in various settings in the recurrent setting, and found that in many cases, treating with doses that were the dose equivalent of about 40 to, I would say, 80 gray, they found that for many of these patients, again, even in the recurrent setting, they were living over a year. So at the time, in the 80s, this was somewhat provocative, and I think helped further propel the use of brachytherapy. So then we move into the sort of current era of interdisciplinary management. The advantage of brachytherapy, again, these are radiation sources that are implanted at the time of the surgical intervention. And that the benefits include that you have radiation starting immediately at the time of the tumor removal. So there's no delay. This is when you have the lowest burden of potential microscopic tumor. You also have this rich milieu in the post-surgical environment of many potential pro-growth factors that can otherwise spur forth recurrence. And so when we see episodes of rapid recurrence, this may be a way to address and obviate that. It also ensures adherence to treatment because everything is packaged as a single procedure. And there's some dosimetric advantages I'll show you that permits dose intensification to the surgical wall and a very steep dose gradient into the brain parenchyma, which can be certainly valuable in the reirradiation setting, as I noted before, that prior radiation bestows the greatest risk of potential radiation injury and subsequent reirradiation for often recurrent disease. So again, noting that this is done in conjunction with surgery, and there remains a role for surgery, certainly for larger symptomatic lesions that need decompression, needing for tissue diagnosis in this current era. We may see changes with CSF analysis and tumor-free DNA later on, but right now it's still important, especially in the initial setting and in the setting of unclear recurrence versus radiation treatment. So this is an opportunity for a patient undergoing a craniotomy and a resection. Brachytherapy might be employed. It's also important to note that though we have made great strides in having new CNS penetrant disease, radiotherapy is still a standard of care following resection, even in the era of CNS penetrant therapies. Now, for the most part, that adjuvant radiation therapy has been happening in the form of postoperative radiosurgery to the surgical cavity. There is an emerging role for preoperative radiosurgery and brachytherapy, as I'll show in moments. But in many studies, including some of our own work, even with patients with CNS penetrant therapies, modern TKIs, immunotherapies, in the absence of adjuvant radiation, there is a high likelihood of recurrence post-resection. Also in the recurrent setting, I just put up this slide, some of the work that we've done and others have done, just really highlighting how challenging it can be for patients who have been previously treated, whether it's been with upfront surgery, radiation, when there is or are imaging changes following treatment, discriminating between or distinguishing between recurrence versus pseudoprogression is very challenging and can result in delays and further tumor progression. So surgery as an intervention is able to then distinguish recurrence as a gold standard with pathology versus pseudoprogression. And of note, studies such as this actually show that in many cases, going into a resection for a question of recurrence versus pseudoprogression, we're often wrong in terms of our radiographic assessment. And so surgery remains the gold standard. So I mentioned that package time can be important between recurrence and following resection, that we want to treat with stereotactic radiation very early on, and that patients who have delays more than a few weeks, you can see a very quick increased risk of recurrence. So the brachytherapy seeds, the implants that we use, this just shows a schema of them. There's different sources. The modern sources are usually cesium-131, and they exist as these very small 4mm seeds. They're encased with a gold marker to be able to see them on imaging, and then in inert packaging. And you can see they're very small, like little filings, smaller than a dime. And so part of the reason that we transitioned from iodine to cesium is that it's a much shorter half-life. Cesium has a half-life of just under 10 days versus iodine, which has a half-life of 60 days. And this is just an example of a cesium stranded seed implant that we did for a patient who had recurrent disease following radiosurgery for a urothelial cancer. But the reason that we use the cesium is that these surgical cavities collapse over time after resection. And because of that, it can impact the dosimetry. And delivering the radiation a little bit faster over 10 days versus over 60 days, per half-life, can afford better dosimetry. And that's illustrated here. That's illustrated here. We get steeper gradients and more, I would say, directed prescriptive dosimetry when we use cesium sources. So to date, there's been over 30 studies that demonstrate efficacy and safety. And I'm going to take you through a few of them, but I want to point out, whereas historically we've used free seeds or stranded seeds, they have the potential to be placed in a way that doesn't fit with the sort of preoperative, thoughtful, prescribed potential dosimetry. You need to space them apart, and they can migrate. The gametile delivery system, which has been in practice now for maybe about a decade or so, places these seeds, 4 seeds in each one of these collagen matrices. and allows spacing between them, which helps to give, as you see on the right here, some of the best dosimetry possible, a little bit more homogeneous spacing, and we think that this could be important in terms of prescribing the dose as intended based on preoperative planning, and limit certainly seed migration and potential injury from having seeds being migrating too close together. And so the implants can look like this, and you can see how they're placed, even spacing within a surgical cavity. So this is something that I employed to treat that patient I mentioned in 2014. We did a resection to confirm the fact that this was in fact recurrent disease now 5 years out from initial radiosurgery treatment, and implanted the patient back in 2020, 2021, and has been disease-free since. So I'll talk you through some of the data very quickly, just to finish up. Much of this has been single institution work coming out of Cornell, Memorial Sloan Kettering, UCSF, amongst others. In the recurrent setting, brachytherapy has demonstrated significant efficacy and safety. You can see upwards of 80 to 90% local control in the area of recurrent disease. Expected patients can still develop metastases distantly. But in terms of the efficacy is excellent in small cohorts of patients. This was our series. You can see similarly local control 83%, and very few cases of radiation injury for these patients, even in the recurrent setting. Similarly, Memorial Sloan Kettering, excellent local control, upwards of 90% in the recurrent setting. And so this is something that's been employed commonly. There's been increasing interest in treating now in the upfront setting. So you have a single large brain metastasis that's appropriate for resection. Using this in the upfront setting may have utility as well. And I want to point out, here's data from MCI in the recurrent setting, that the dosimetry in the recurrent setting can be excellent. You can get very high doses as compared to other radiosurgery modalities with brachytherapy and gamma-tile, but without giving significant dose and looking at those volumetric dose considerations that put patients at risk for injury. So in the upfront setting, there's been a number of initial studies done that demonstrate again, safety and efficacy and ability to overcome this potential rapid early recurrence. And studies that were done out of the Cornell group, again, in the sort of matched first retrospective setting, have shown that as compared to brachytherapy at the time of surgery, postoperative radiosurgery was associated with increased numbers of local failures, with no difference in terms of radiation necrosis. And so a phase 1/2 study was undertaken by the Cornell group with 24 patients, showed 100% local control with initial brachytherapy at the time of resection up front, with 0% risk or cases of radiation necrosis. In the last few minute or two, I just want to point out what I think is some real exciting data that was just presented at CNS. This was by Dr. Weinberg and Dr. Beckham from MD Anderson. The gamma-tile group had sponsored this ROSE study, which is a phase 3 randomized controlled multicenter trial for newly diagnosed brain metastases, randomizing patients to either surgery and then adjuvant radiosurgery versus surgery with brachytherapy, and stratifying by 1 or 2 to 6 brain metastases, with the primary outcome being surgical bed recurrence-free survival. So they did an interim analysis with a median follow-up of close to 9 months, 168 patients that were fairly well balanced of various histologies. And what they found is that as compared to postoperative stereotactic radiation therapy, there was superior surgical bed control even at this interim analysis, with the median time to recurrence not reached, and the stereotactic arm essentially mirroring what has been shown from other studies from MD Anderson, Dr. Mahajan, and other groups, with recurrence at 1 year on the order of 70 to 80%. Local control, 20 to 30% local recurrence. And similarly, when you look at composite endpoints with recurrence or radiation necrosis, the brachytherapy arm was superior. When you compare to recurrence-free survival versus or recurrence-free survival as composite endpoint and death, also superiority for brachytherapy. I'll just point out that there are a number of events that were happening early on that will need to be examined further amongst the investigators. But I think you look at the rates of radiation necrosis, leptomeningeal disease, adverse radiation effect, also well matched between the two. And so this brachytherapy intervention certainly seems as safe as our current standard practice of surgery with stereotactic radiation therapy. And so they conclude, at least at this interim analysis, that based upon the methodology, that the brachytherapy intervention is superior in terms of recurrence bed-free survival. And we await for this to be published and the full results hopefully forthcoming within the next year. So I'll note that they have a number of clinical trials in their portfolio, not just for metastases, but also for primary CNS disease, including glioma, using brachytherapy at the time of resection. And so in summary, I just show, looking at brachytherapy versus radiosurgery, for patients who are undergoing or candidates for surgical resection otherwise, brachytherapy, of course, combined with surgery, has the benefit of relieving mass effect, getting tissue for diagnosis. It's a single packaged procedure. There's the potential radiobiologic benefit in terms of dose and timing. Certainly data we're seeing that supports safety and efficacy, opportunities for other surgical procedural interventions. However, the experience for radiosurgery remains fairly extensive with decades of research. You can treat multiple lesions, whereas brachytherapy is really used for one or two surgically accessible lesions. It's non-invasive. And we're thinking about now how to widen that therapeutic window using fractionated radiosurgery techniques, using preoperative radiation techniques. So I think when you look at the future trials, when we're comparing, it's nice to have this additional tool to be able to help patients in certain settings. But I think in the perioperative setting, as we combine radiation with surgical resection, having NRG, I think BN012 recently closed. We're excited to see how that reports out. That was preoperative radiosurgery. There's folks also doing preoperative fractional radiosurgery. So I envision there'll be a future clinical trial comparing brachytherapy with preoperative radiation. So with that, I thank you, and then I'm happy to take a question or two if we have time.
Steve, that was excellent. Do you have time to stick around for the panel discussion at the end of your
Of course. Yes.
session? Is that okay? Yeah, we'll hold the questions until the end if that's all right with you.
Great.
Excellent talk. Thank you. I think, Max, did you want to introduce Dr. Goodwin?
Yeah, that'd be great. So it's my distinct pleasure to introduce our next speaker, Dr. Rory Goodwin. Dr. Goodwin is an associate professor of neurosurgery at Duke, where he serves as the director for spinal oncology and the surgical director for the Duke Center of Brain and Spine Mets. He got his MD and his PhD in neuroscience from Johns Hopkins, where he also did his neurosurgery residency, as well as an enfolded complex spine fellowship. And coincidentally, I also met Dr. Goodwin when I was a sub-I at Johns Hopkins, and he was a junior resident. So it seems like yesterday, but apparently that was a long time ago. Dr. Goodwin's lab studies translational biomarkers and clinical outcomes for patients diagnosed with spinal tumors and genomic and proteomic predictors in brain and spinal oncology. His research in spinal oncology has received funding from the UNCF Merck Science Initiative, the Burroughs Wellcome Fund, Robert Wood Johnson Foundation, and the NIH. So with that, Dr. Goodwin, the floor is yours.
Thank you kindly. So hopefully everybody can hear me, because I'm going to do this a little bit different than normal, because I know that I have Dr. Palmer kind of coming after me, who's really kind of the heavy hitter / big gun, who's going to tell you all about spine oncology. So I figured that what I would do is give you some of the kind of updates in terms of the thinking from a national level. So I'll be talking about kind of the frailty of success in metastatic spine disease. In brief, these are my disclosures, not really as relevant overall. But really, I figure what we could talk about is kind of the S in gnomes. I think that it's something that we've very rarely discussed, and it's something that I think some of the other speakers have alluded to in terms of, whether a patient is able to tolerate kind of certain therapies and whatnot. We'll talk about the concept of frailty, assessment tools, perceptions of frailty, and frailty predictions, and then brief summary. So I just want you to think about this case as kind of a starting point, and it's something we'll revisit at the end, but it's a 65-year-old male, history of Merkel cell carcinoma, 2-week history of progressive difficulty walking, urinary incontinence, T5 epidural mass, solitary, cases of the spinal cord, high-grade spinal cord compression. So just kind of think about that case as you're thinking of it, when you see that patient come in. So in brief, when we think about spine tumors, we know that they're common, and it's estimated that about 40 to 70% of patients are going to get this at some point during their clinical course. And, the majority of them end up having sensory problems, weakness, pain, bowel bladder, incontinence, or paralysis. And it's thought to be about 2 to 10% of those patients will develop some form of spinal cord compression that'll end up needing some type of intervention. And we know that this incidence is increasing because of advances in our detection therapeutic strategies, and that these patients are at risk for poor overall prognosis, as well as health-related quality of life. So when we think about the decision-making framework for metastatic spine disease, it really kind of goes back to this NOMS criteria, which is basically divided up into kind of 4 parts, the neurologic, the oncologic, the mechanical, and the systemic. I think the neurologic is pretty straightforward in terms of, the patient's neurologic status, what the degree of compression on the spinal cord. The oncologic is if it's radiosensitive or radioresistant, or basically its sensitivity to systemic therapies. Mechanical is just instability. And then there's this category over here called systemic, which really boils down to, if you look at all the literature, it's is the patient able to tolerate surgery or is not able to? And so when we think about NOMS, really, it's kind of, we break it down into this category. So if you have low-grade epidural spinal cord compression, radiosensitive, you want to think about conventional radiation. If you have, if it's radioresistant or previously radiated, and you don't have a neurologic deficit, you want to think about, SBRT or SRS. If they have high grade and it's radioresistant, you want to think about separation surgery followed by the SRS. And then if they're unstable, you want to stabilize it. If they're able to tolerate surgery, separation surgery. And if they're not, then go into radiation. And that's kind of like a very crude way that we think about the framework for NOMS. But, really it's that last one in the systemic. That's kind of what I want to talk about, is that how do we actually decide whether a patient is able to tolerate surgery or unable to tolerate surgery? And so we have a whole host of different decision-making algorithms and scoring systems that serve as a framework to kind of guide not just what we do, but whether we should do something and the appropriateness of surgical intervention for any given patient. And really, just to make it kind of, simplified, it's who should we operate on overall. And why is that important? You have to remember that this is a population that has a limited life expectancy, and the goal is really to maximize their quality of life while minimizing complications or risks. And you could equate getting a complication to this meme that I'm showing you here, in which basically if you get a complication in these patients because you didn't take their frailty in account, you can kick them off the edge of the cliff, so to speak. So when we think about the surgical decision-making of who we should operate on, the risks and the complication profile and all that all factor into that. And I think that the importance of that is kind of figuring out, or understanding, I should say, where that patient is in their overall disease process, right? And that's how you're going to actually improve overall quality of life. So when we think about this, we think about the concept of frailty. And in the metastatic spine disease literature, the AO Spine knowledge form kind of defines this as a patient phenotype of multi-system diminished physical reserve or capacity that predisposes you to worse outcomes. And really that ends up dividing it into, those patients that are frail, that are robust, frail, or disabled. And I have that cartoon at the bottom, which shows you somebody walking all the way to somebody in a wheelchair. And what we're talking about is actually what is their resilience level, right? So somebody who is robust, meaning that they're able to tolerate any stressor that you put on them and come out on the other side kind of the same, versus somebody who, cannot tolerate those stressors, or somebody that's frail. And if you were to stress them with something like surgery, what would actually happen to them in terms of their ability to kind of functionally recover versus those individuals who have no intrinsic capacity. And so those are the individuals that do poorly. So when we think about that, we started to kind of make an overall go about this systematically, and this is something that has been a focal point, I should say, of a lot of the international spine tumor study groups. Looking at that gnomes framework is like, how do we do that? And excuse me, when we think about that, what we ended up doing is we did a extensive systematic review where we looked at what are the systemic considerations for surgical treatment for spine mets. And with Mark McLean, that's listed here on the right, as the kind of the lead author, we did a scoping literature view where essentially what we did is we looked at every single systemic variable in the literature regarding this. So that's their demographics, medical comorbidities, systemic disease burden, health-related quality of life, disabilities, you name it. And then we looked at whether or not those were positive or negative predictors of their clinical outcomes. And you can see the clinical outcomes there that we actually investigated. And then we looked at that to determine, like, okay, what are the specific factors that we should be taking into consideration? This table just kind of shows you overall all the different factors that we found over the course of the entire literature. And what we wanted to really look at is that what are the tools, or how can we design ways to look at frailty in an objective manner? And when we looked at all these tools and we looked at all of these, comorbidities and factors, what we actually found is that the frailty tools lacked, or they had uncertain content and constructability. They had floor or ceiling effects. The metastatic spine tumor frailty index was the most studied and most frequently used, but it lacked predictive validity. The hospital frailty score had positive predictive validity, but it lacked feasibility for use in the clinical setting. And none of the frailty tools or factors that we actually identified through these studies assessed for reliability, responsiveness, or were used to track the frailty trajectory, which I think is the most important. I think we've all seen patients where once we start, when you see them, at one point in time, if you look at them 2 months later, they're in a completely different state. And I think that's important to note. So kind of looking at that extensive literature of all the things that these patients go through, we then said, hey, this is what we say we do in the literature. But then we took a step back and we say, well, what do surgeons actually use to assess this when they look at that S in gnomes? And really, we use the eye test. And that eye test is basically when you stand at the door and you look at a patient, you're like, does this person look sick, or do they look like they could actually tolerate the surgery? And I think that's important because when we try to translate a lot of these factors, a lot of these tools, one of the things that we're trying to do, especially in the AO Knowledge Forum and kind of all these other study groups, is we're trying to figure out how can we design tools and other kind of scoring systems that surgeons and clinical providers and medical and everybody else will actually use. So the first thing that we decided to do was we actually did a survey of all the surgeons, say, okay, well, what do surgeons typically use when they look at frailty in these metastatic spine disease patients? And what we found was that the top 3 things that they look, and this was basically done as a Likert scale where basically participants were asked to rank their level of knowledge of basically whether they thought that this factor was important overall for determining a patient's frailty. The top 3 answers that were chosen were severe comorbidities, extensive systemic disease burden, and poor performance status by surgeons. And this was one of these 3 factors were the ones we decided to first start investigating. So when you look at those 3 factors from a performance status standpoint, what we decided to do was to look at what was a specific tool that surgeons use to decide frailty, and what was the most indicative tool when we did this through a modified Delphi approach that we thought was the most objective way. And we decided on ECOG. So basically whether or not that patient, and really it's even though we know that ECOG is stratified into these 5 criteria, we really decided to make it into 2 criteria, which is that patient ambulatory or are they not? Second was comorbidities. And so using the MFI-5, we basically just used these 5 criteria: diabetes, hypertension, congestive heart failure, pulmonary disease and a non-independent functional status to address that, and then overall disease burden, so the number of sites of metastasis, their current systemic treatment, and then basically the histology of that disease. And these were seen as the objective measures of frailty that most surgeons use to basically decide kind of whether or not to operate on a patient. So as a kind of scientific group, what we decided to do is to take those frailty tool performance metrics and we put them through our retrospective data, our prospectively collected retrospective database of about almost 1,300 patients from 19 international sites. And these were patients that were enrolled from 2017 to 2024. And we asked these questions: what are the patient's oncologic factors associated with mortality at 90 days? And what are the patient oncologic factors associated with non-home discharge? So what's the likelihood of that patient dying within 3 months? And what's the likelihood that you can actually get them home after a surgery? And when we looked at these, we found that in terms of predictors of that performance status, predictors of that mortality at 90 days, when you looked at performance status, you had a 1.8 odds ratio of actually that being a predictor of mortality. Charleston Comorbidity Index basically was about 1.24, and then we had and things like BMI was a negative predictor for mortality at 90 days. When you looked at disease burden, if it was a new presentation, that was actually something that would predict that, yes, that person should survive greater than 90 days. But then the site of the primary tumor, total number of metastasis, and then presence of brain and visceral metastasis were positive predictors of that person dying before 90 days. And, you can look at this and you can say, that's great. But when we put this together in the model, we found that, the AUC was 0.72, which was in that kind of acceptable to good range for predicting mortality at 90 days. When we looked at non-home discharge, we kind of found similar things where performance status was a positive predictor, 2.5. Race was interestingly almost a fourfold predictor of non-home discharge. And your presence of metastasis at other site was almost twofold. If you got prior systemic therapy, that was actually a negative predictor of non-home discharge, or in other words, they were more prone to actually go home in that case. So when you look at all of those factors, and the model for this was actually better in that the AUC was 0.76. So when we looked at all these factors, and this is kind of the summation of this first part, is that usually we're very good at, that eye test. But I think that what we actually found is that we need to figure out better ways of looking at frailty and looking at that systemic burden of disease. And so one of the things that I'm mentioning is that we're taking this as kind of a foundational starting point, where we're now going to actually move forward with other factors to create a comprehensive scoring system that any surgeon, any medical oncologist, any radiation oncologist can use in order to determine whether somebody is frail or not to tolerate a surgical procedure. And that, I think, will make it easier for more communication, basically amongst our colleagues, but then also to the patient of where they are in their overall disease burden. So the next part that I'll kind of go over is, now, how do we use that information to help patients make the best decision for them? And so we know that these spine pathologies are challenging. And so what I want you to think about is that same case I showed you before. How do patients actually think about, making decisions, right? What would your mind state be if you were diagnosed with this spine problem? What's important for you to know when making a decision? And how would you make the decision to pursue surgery? And those are all important, because we can say that, you have visceral and brain metastasis, you have this, that, the other. But at the end of the day, we also know that for all of these different patients, when they first get that diagnosis of, hey, you have a spine metastasis, or hey, you are unable to walk and you may never be walking, there's a shell shock component to it. And it's important to note, I always like to quote the gangster poet, who was the Pulitzer Prize winning rapper Kendrick Lamar, and that, when you talk about perspective and how that perspective is influenced, you have to realize that your perspective may differ from the person that's across from you. And I think that's important when you think about spinal pathologies, because these are very complex treatment decisions. And the thing about it is that the patient and the provider have to have a mutual understanding of those treatment goals, what are the benefits and what are the risks? And then what are the specific factors that you have to consider when you think about that patient's overall satisfaction as well as the outcomes. And we know that there are a few studies that examine those perceptions, those expectations, and all those factors that influence decision making. And I think that's important to note because, overall, this is the patient-centered model that was adapted from Cobb et al. I think when we think about how patients make decisions and how we think about that frailty and that systemic burden of disease, so to speak, I think a lot of clinicians think of it like this in terms of these are the factors that patients use in order to decide, hey, this is how I'm making a decision. I'm thinking about what are my attitudes, what are my beliefs, what are my communication barriers, what are the perceptions of this disease process, how is that, how is my interactions with my medical provider, do I have trust in this process, all those things. And I'll tell you that I used to think this way as well until I actually went to one of the focus groups that I have, and this is just my spine tumor support group. And I asked them, I was like, this is how I think that we make decisions, but how do patients actually make decisions? And what they actually told me is that, oh, it's not even nearly that sophisticated. They told me that usually when they make decisions, it's usually a combination of this pie chart, which is that, sometimes they're thinking rationally, sometimes they just flip a coin, a lot of times they send in panic, and more often than not, they actually pray that someone else makes the decision. And I think that's where we as kind of providers and clinicians can really provide a lot of that consultation and consoling, for lack of a better way of putting it, to help them make these decisions. Now, the interesting thing and why I kind of bring up how do patients make those decisions, I think that one of the things is that when we think of frailty, we think of it often from the standpoint of when you look at a patient, like, can they tolerate this or not? But the other aspect of that is basically, do they have the cognitive resilience in order to basically tolerate that surgical procedure? I think we all have also had patients where, regardless of how much you console them, they just can't fathom going through a surgery. And that at the end of the day, they're not able to kind of tolerate it mentally. And that mental portion then influences their inability to get up and walk, get out of bed, do all of those simple things that are going to be conducive to their overall care. And so I asked myself, and this is one of the questions that we're going to be addressing from an international level, is what influences a patient in terms of them going from this right-sided panel where they're basically praying someone else makes a decision and oscillating between panicking or flipping a coin and kind of the thinking rationally. And what we found is that the biggest thing that actually influenced that is basically distress. And so that decision-making primes them or influences, the distress influences or primes that decision-making and allows it. So what is distress? Well, distress is, if you look at the National Comprehensive Cancer Network's definition, it's a multifactorial, unpleasant emotional experience of a psychological, social, or spiritual nature that may interfere with the ability to cope effectively with the disease, its physical symptoms, and its treatment. And there's numerous factors that contribute to that as outlined here. And I think that, one of the things that is, I think at the forefront of that is that we know that as patients get the diagnosis of cancer, they have their physical burden of disease that manifests in that declining functional status that interferes with their overall daily activities of living. All of these combined with the emotional and the social changes associated with their cancer diagnosis can influence distress. And we know that up to 60% of cancer patients experience clinically significant levels of distress, and that worsens those outcomes, worsens their quality of life, decreases their treatment adherence, and then possibly lowers their survival rates. And we can measure this because, as we all know, the NCCN guidelines basically recommend giving every cancer patient a distress thermometer. And this is just an example that you can see here that shows you like the distress thermometer that we use at Duke. And it shows the problem list of what are the problems that patient experiences, with basically any level above 4 indicating a significant level of distress. And so what we decided to do is look at when are patients most vulnerable to distress. And through a excellent medical student, Dana Rowe, she basically did a systematic review of the literature and found the times when patients were most susceptible to distress. On the left is basically your preoperative baseline. When you look at from surgery to discharge at 30 days, those are really the highest levels of distress, and that's when they have clinically significant distress. It actually goes down over the course of the year, and actually, if you look at specific subtypes, it actually goes up at the 1 year mark, and it's thought to be because that's usually when patients get that surveillance imaging, looking at whether they had any recurrence of disease or anything like that. And you can look at the different predictors of distress. And this is basically younger patients, lower income patients, single patients, females, racial and ethnic minorities. And what this actually points to is that we need to identify ways to target distress in the spine tumor population through enhanced patient-doctor communication, supporter advocacy groups, increasing support, counseling, and navigation. And really going back to what I was saying before about improving their cognitive resilience is that we really need to get patients ready cognitively. And so in my own practice, what I use is verbal and written risk sheets, palliative care consultation for goals of care, stress management consults, anytime that a patient has a length of stay over 1 week, psychological counseling or consultation, chaplain services, support groups, but really trying to enhance that communication to put patients in the best possible position so they can meet their overall goals of care. And we can have a system where number one, they are able to basically benefit maximally from any intervention that we do. And then number two, we can basically facilitate as providers goal concordant care. So one of the programs that we've done, and we're trying to roll this out at some other institutions, is this Spine Patient Navigators program. And this is an undergraduate program where we get undergrads and medical students together, and they serve as liaisons between patients and surgeons. They actually help communicate with them and connect them to all of the different healthcare resources and engage patients in the immediate postoperative phase, predominantly just to provide that emotional support. And these are things that we think are super important. I kind of went through this already in terms of getting that mutual understanding. And so, I'll close by kind of returning to that case that I showed you before. So 65-year-old Merkel cell carcinoma, difficulty walking. So when you look at this patient, one of the things that was important is that we ended up the patient said they wanted everything done. They said that they wanted to tolerate this, they could tolerate this surgery. They wanted to get through because they really wanted to just get out of the hospital, get back to walking. So they were like, do everything. I have the cognitive resilience. But from a physical frailty standpoint, they really couldn't tolerate it. And I had done this case when I was a resident. If you look through the literature and you look at that tumor type, you look at this performance status, you look at all those factors that we saw, even though we did this surgery, which we did this T5 corpectomy, the cage, and we're high-fiving everybody after we do the surgery, like, yeah, we did the right thing. If we had kind of looked through that same algorithm that I just showed you in the past, basically you would have seen that there's poor survival no matter what's done. And this patient ended up dying 1 month after surgery. And the main reason why is because the frailty that they had from a physical standpoint was not sufficient in order for them to overcome the stressors of their disease burden and surgery. On the flip side, I'm going to show you this other patient. This is a 75-year-old male, past medical history of SVC syndrome, peripheral neuropathy, T1 metastatic yolk sac tumor, and neck pain. Ended up having this T1 met, 50% height loss, Bilski 1C epidural extension. He ended up getting surgery at an outside hospital, C5 to T2 posterior spine fusion, had a wound infection, and ended up getting an incision and drainage, was on IV antibiotics, underwent SBRT, had salvage therapy with Keytruda, and then he presents to me with neck pain after undergoing all of those about a month later. He ends up coming back with severe neck pain, and you can see from this video that basically he completely pulled out all of his screws. His bones were actually sliding forward, and he was grossly unstable if you look at all of our scoring systems, and he had severe spinal cord compression at that level. But he was walking around, and part of it is he had the social support around him in order to make sure that he was cognitively in the right mind state. So despite all of these stressors, he was actually doing fairly well. We ended up taking him for separation surgery. We did this surgery where we separated the tumor from the spinal cord. basically did a comprehensive fusion. He ended up getting 5 grade times 5. And afterwards, he then went on to, number one, get back to walking. Because when he came into clinic originally, he was in a reclined position. He was literally in a wheelchair, but didn't want to get up. Number two is he ended up getting off of a lot of his pain medication. And then number three, he got back to doing the things that he wanted to do, but he had a positive outlook. And I think that that cognitive frailty, basically, you know, he was one of those cognitively robust patients that could tolerate all this, you know, even though he was the same age as that other patient. So, in summary, and this is kind of where I'll close, I just want you to remember that frailty is a patient phenotype of multisystem diminished physical reserve or capacity predisposing to worse outcomes. A lot of the frailty tools that we currently use lack or have uncertain content and construct validity, and we really don't track the trajectory of it. Most surgeons perceive performance status, comorbidities, and disease burden as objective measures of frailty, and it's important just to remember that the patient goals, priorities, and expectations, as well as minimizing harm, are the foundation of treatment. And you have to remember that frailty consists of that cognitive frailty as well as the physical. So I'm just going to leave you with this, and that basically you have to remember that it's all about balance. So the surgical goals, the frailty, the invasiveness, you have to put all those things together to find the right surgery for the right patient for the right reasons to get the best outcome. And so I'll tell you that with that, you know, this is the AO spine knowledge form tumor where a lot of this evidence is. So everything that I'm showing you is all things that we've kind of done in the past year. And this is my lab that is doing some of the work as well. So with that, I will stop there and take any questions at the end.
Fantastic talk, Dr. Goodwin. Thank you so much for sharing your expertise. Just so many practical pearls coming out of that with regard to decision making and appropriateness for patients that are going to go to the operating room for spine mets. It's awesome, and I think provides an excellent springboard to our next speaker. I just have to also give you a tip of the cap. For the first time in my professional career, you know, having a really appropriate Kendrick Lamar reference, I think was absolutely fantastic. So thank you. You know, that was just great. So our final presenter.
Thank you to the organizers.
Wonderful, thanks.
Just a great talk. We do have a couple of questions from the group. Let me take our participants' questions first. To Dr. Goodwin, how would you assess frailty for metastases to the brain and meninges? Or meninges, sorry. How would you assess frailty for metastases to the brain or meninges?
Yeah, so I think it's actually very similar. I think, you know, is it Paul Sperduto, like all the trials that he's done, like, I think that there's a lot of overlap with the systemic considerations. I think that it's one of those things where in the brain, the one thing that I think would be interesting to note is that, yes, I think you're going to look at the systemic burden of disease and all those other things, but I do actually wonder about the cognitive standpoint from brain, because I think that's something that we don't really deal with as much in the spine in terms of how does that tumor actually affect your baseline cognitive function, so to speak, right? Like whether, you know, you're getting whole brain and you're thinking about like the cognitive effects of those. So I think that it's going to be, so the short answer is I think there's going to be an overlap with everything that we do in the spine. And I think there is already, but I don't know what are those additional effects with the brain because of that whole cognitive frailty piece that I would bring up, so to speak.
Yeah, and I have to agree with you. You know, I had just chaired our the American Society of Therapeutic Radiation Oncology panel for looking at the updated guidelines for glioblastoma management, and we had actually just recently highlighted within that document the assessment of frailty in terms of the rigor of therapies that are recommended for patients. And there is actually a website that we highlighted within that manuscript that I think you had alluded to as well, Dr. Goodwin. efrailty.org is a medical assessment tool that we had used at least in GBM patients, but I think could probably translate across all central nervous system disease in order to assess how physically fit somebody would be to undergo some of the things that we recommend for them. So yeah, I think your points are very well made.
Along the same line, that was a great talk, Dr. Goodman. What are your thoughts? Frailty is different based on the invasiveness of the treatment we're proposing. The frailty for neurosurgeon who's going to do multi-level fusion is very different than medical oncologist, say, who's going to do chemotherapy. So when we're giving a multidisciplinary kind of recommendation to patients, so many times I feel like they're here where, some people, oh, we have third line, fourth line, fifth line treatment still available for you. And then we're saying, that this is not very, surgical. So I feel like patients many times get this various level of what the true risk is. Can you speak to that?
So I think you're getting at one of the, so when we discuss frailty, I think that you're getting at the crux of one of the issues, and that is that I think, in general, and I think this kind of highlights the importance of these multidisciplinary tumor boards, is that usually when individuals are highlighting like, okay, whenever is somebody able to tolerate my specific effects, we're not really thinking about it relative to the entire natural history of the disease and where they're going. And I think that we end up being siloed in terms of how we think about it. For instance, patient with a primary tumor that I'm going to en bloc and I'm going to take out half of their, chest wall or whatnot. Yeah, they may be able to tolerate that, but then if they have to then undergo the chemotherapy and everything else, like, did I really do that person a disservice or service by doing something majorly invasive? And so I think one of the things that we have actually done, and this is kind of, we haven't published it yet, is we've actually started looking exactly at that question. We published a couple of papers looking at it from the systemic therapy. So that way, as from the surgeon perspective, it's like, okay, what are the 3 questions that I should ask with my medical oncologist, right? In terms of things that would impact that, right? Like what line of therapy that they're on, I think is an excellent one, right? What, are they on a agent that will modify that complication profile, right? Are they on Avastin versus are they on a Taxol-based or a platinum-based chemotherapy? And I think that all of those things together, that, when we start thinking about these decisions, we have to start thinking of it, from a multidisciplinary kind of perspective, right? Like one of my mentors said that one of the best lines, and I think this kind of speaks to it. He was like, don't think like a spinal surgeon, right? Think like an oncologist, right? And if you can't do that, then you shouldn't be doing the surgery. That's kind of what they pretty much said. And I think that that's the advice that I've been looking at it from, like, what are all of the different systemic things that this patient is going to undergo over the course of their treatment strategy, so to speak,
Well, I have a follow-up to that one. Really great talks all around. Roy, as I'm listening to you, I'm thinking of a couple concepts that sort of lead to a few questions. So one, which you mentioned about thinking like a medical oncologist. I read an article not too long ago about this concept that was new to me called something like time toxicity, or basically that when you're thinking about somebody's remaining quality of life, factoring in how much time they have to come into the hospital for the treatments, and sort of that just sort of spun off. So my question, I have 2 questions. One is, do you consider the reversibility of frailty in your equation for frailty? So like in other words, like if their major frailty driver is immobility, but a surgery might cure their immobility, how do you incorporate that? And then the second question is, for when you do end up with a patient who's too frail for surgery, I think at our last conference, we had a lecture from the MD Anderson guys talking about spinal lit, and basically for that subpopulation. Have you looked into that, or are you curious, or where you fall on that?
Yeah, so I think it's kind of twofold. I think, one, like everything that Josh presented was like, spot on. First of all, Great talk. Love to hear you speak. Just so you know, I'm just going to put that out there. But I think that the first part of it is that the factors that we previously were looking at, we were looking at some of them that were unmodifiable, and we didn't really think about, well, how should we start thinking about modifying it? And so part of the thing that I've started doing is for those modifiable risk factors is basically going through a comprehensive preoperative optimization strategy. So the easiest one that you can think of is, their nutrition status, right? And so nutrition status associated with poor wound healing, which increases your mortality, non-home discharge, all those other things. So one of the things that I do now, just as an example, is basically get a pre-albumin level and albumin level. And then we've done several nutrition things where, my thing is that you're going to get a nutrition consult. And we've actually published on it saying that nutrition consults lead to better overall clinical outcomes overall. And then get them on a protein shakes. And we kind of do all those things ahead of time. I think for a lot of those things like mobility, it can sometimes be hard. But one of the things that one of my patients said, and I haven't done this yet, but I want to, is they said, if you were to come up with a way for people to move, like almost like chair yoga, that would be the ideal. So that way they're moving and they're not necessarily getting worse, but you're maintaining wherever they are as they wait for surgery or whenever, and then you're using that as a modifiable risk factor, quote unquote, in terms of their movement rather than their walking. And it's an interesting concept. We actually tried it, and the patients like it, interestingly, the chair yoga and whatnot. But I say that is like, those are things that I try to also take into account, because I think that those are actually the more important ones, because there's certain things you just can't fix. But I think on the flip side, that's what we should be focusing on. I think the first thing you brought up is, the time. And I think that is super important, because we looked at it from like a quality adjusted life years and kind of how that actually influences everything. So it's not just, how much quality of life they can get back, but, how much time that they have. And then am I taking away from it in the hospital? The second question that you had was, what was the second question that you had?
LIT for frail patients.
So we actually do that a lot, radiofrequency ablation, lit, kyphoplasties, simple perfusions, like all of those treatment strategies. We started using those as kind of adjuncts for those frail patients, and they work very, very well. And I think you also see, I'm waiting to see the data on like lit plus SBRT in the spine that I'm sure that Josh is going to do, and I'm just going to start, following his lead. So I think that's going to be a great. I think those are all great things that everybody should be doing, for this patient population.
I was just going to point out that I think is a great sort of segue to, there's a number of papers now looking at this term prehab. So like prehabilitation prior to surgery. Like WashU does this. That's kind of essentially what Rory's talking about, of getting some sort of exercise in, breathing exercises, nutrition, all this stuff done in some time period, limiting alcohol, limiting smoking, limiting like a number of these things right before surgery. And there's like some prospectives data now, I think out of WashU, where that actually improved surgical outcomes. And so I think that's a really cool kind of intervention, especially in spine oncology, this idea of sort of doing prehab while they're getting ready for surgery.
Yeah. And actually, my pre-op nurse just came in here, and she was like about to like beat me up. But she does my pre-op education, and she reminded me that actually we work with physical therapy, and we get a pamphlet that actually shows them what are how to get up out of bed when they're in the hospital, like how to get up and actually stand up and just march in place, and using those as adjuncts that the patient can do while they're at home, relatively safe. They just literally learning from like sitting to standing, just like what are those techniques, so that way they learn all those things beforehand for that specific thing in terms of rehab. So yeah.
Steve, I did have a question for you, just with regard to some of the data that you had shared at the end.
super amazing long-term control with GammaTile to those resection cavities. And I guess maybe I've been led down a pathway of thinking that I was doing a good job with just treating the cavity post-operatively. You know, we've done a lot of transition to pre-op treatment, which I think has also shown incredible promise, and you know, love those opportunities when we can engage with surgery when patients are in-house to make a decision as to whether or not we're going to do pre-op versus post-op. But I guess I was a little struck by how poor the cavity control was on the post-op SRS arm in that data that you'd presented, and wondering if you could comment on the rigor associated with cavity delineation, volume expansion for treatment, and if you think that plays in at all to what we're seeing as far as poorer control to those cavities.
Yeah, absolutely. I do think that the planning approach to postoperative SRS is nuanced and also evidence-based, that there are features that can augment local control, including targeting the cavity tract, especially along the dural margin, which is now done, I'd say, more routinely after publication of a number of key pieces of evidence suggesting failure patterns being particularly in that area if the surgical tract is undertreated. While I can't speak to the individual cases as presented on this trial thus far, I await their publication, as did the rest of us here. I think what struck me there, yes, is the poor rates of local control when looking at composite outcomes. So they had a number of outcomes that I had presented very quickly that included a local control with death, local control with radiation necrosis. If you look at their pure surgical bed local control, it's around 75% at 1 year, which is on par with what the MD Anderson group had presented in their institutional trial, and I think on par with what we've seen with other institutional work, again, as a function of timing, surgical cavity. I know that for this particular group, the median time for postoperative radiosurgery was a little over a month. I think many of us in practice are treating these patients somewhere between 2 to 4 weeks, and I showed some data that suggests that there's improved postoperative control with earlier treatment than post 4 weeks. The other thing that struck me about their data is that they had a number of events which I think were actually either patients lost to follow-up or death early on, which was somewhat surprising for this group within the first 3 to 6 months. So a lot of patients that are that fell off. Why that is unclear. I think in practice, again, not just thinking about frailty, but just who's appropriate for a resection. Usually taking patients with slightly better assumed performance status who don't have, I would say, any sort of immediate risks of succumbing to their disease. So I think that's something curious to be looked at in the final publication. But in general speaking, I think most of us who do adjuvant radiosurgery are very encouraged by the preoperative data, and where that is technically, logistically feasible, I think more and more of us are doing pre-op radiosurgery based upon, I think, very encouraging data.
And I was just going to highlight, because that Paul had sort of told us that the Alliance data for their trial should be out pretty soon, that they've completed everything. They're in the final analysis phase, and that probably over the next few months we should know if single or multi-fraction is better. And I was going to highlight kind of what you were saying, Steve, that in a postoperative setting, we did pretty rigorous post-plan assessments. So like we did real-time post-plan assessments and quality assurance. We actually had to shut a site down for doing such a poor job of delineating the cavity and planning the radiosurgery. One of the sites on the trial ended up getting told you can't accrue anymore. And so as far as that, but we also see such a wide array of how people do it. It was kind of very mind-blowing of like what people actually do in practice. And so I think that in and of itself, I think adds so much potential to changing the way that local control would occur in a post-operative setting, to the point where I won't say who said this, but in the NRG, we chose not to do real-time assessments of the plannings because we felt we actually want this to be real world and show how bad post-op SRS control rates can be because of this. We didn't want to make it more rigorous and add those layers in the NRG trial. And so that was left out of the pre-op versus post-op trial, which the Alliance did do. Like, we graded them all prospectively and fed back to sites how to change. And so I think that in itself will likely lead to worse long-term outcomes with the post-op patients. And like you said, it's much easier for pre-ops to delineate and it won't change very much, and we're doing it in a much better, tighter timeline.
As a follow-up, Dr. Brownstein, I'm curious to hear what's your thought on like the role of brachytherapy in current clinical practice beyond like clinical trials and experimental settings. You know, is there a role for routine use? I ask because I've been hearing about brachytherapy for a long time, and you know, from what I've read, my sort of impression is that it seems like it's most appropriately used in sort of non-ideal clinical scenarios, like places that don't have good SRS targeting or where they can't get to radiotherapy sooner. And I'm wondering if that's sort of consistent with your impression too, or if there's actually a role in you know, tertiary care academic centers that we might not be seeing yet.
Yeah, it's a great question. I think for many of us, and certainly in radiation oncology or neuro-oncology in general, we're excited about having the application of another tool, just like LIT or brachytherapy in the spine. That was really cool to see, Josh. I think for radiation oncology, it's well established. We recognize that there could be some dosimetric advantages. Really, for what we want to do in basic principle is to be able to deliver dose to targets and minimize dose to off-target regional tissues. And the dosimetry of brachytherapy is really superior to anything else that we have, frankly. You're talking about radiosurgery, proton-based treatment, other particles. It's just really superior dosimetry, but there is this component of it that's procedural, and there's some learning and operator dependence. I think the Gamatol group has done a good job of trying to lower the bar and get folks trained very well. I think in tertiary academic centers, there's absolutely a role if we think that the sort of unique radiobiology and timing that's afforded by doing brachytherapy or radiation immediately at the time of surgery has value. I gleaned over it quickly, but the group also has an upfront brachytherapy implant trial for resection of high-grade glioblastoma, trying to leverage the potential of immediate radiation to be able to offer improved local control in that space as well. So I do think that there is value, but it's really, as compared to, let's say, radiosurgery, we're really just figuring out what are the ideal clinical settings, what are the dosimetric parameters that we should be looking at. All of those much more better established within, I think, the radiosurgery and external beam world, or we're just now beginning to understand. But I sort of glassed over it a little bit. You know, the dose escalation that you can provide with brachytherapy, I think, is even much more powerful than what you can achieve even with single fraction radiosurgery in terms of ablative treatment. We're delivering on the order of about 120 or so gray to that immediate cavity wall right at the surface. That's pretty hefty dose that you wouldn't be able to deliver with most other approaches otherwise. And so I do think in terms of widening that therapeutic window and integrating with other therapies, it can be very, very, very valuable.
So do you think the science is at a point where if we have like a recurrent, say you have a metastasis that was initially treated with stereotactic radiosurgery and that initially good response starts to recur and there's a surgical indication, like there's mass effect edema, that kind of stuff, and you're going to go for surgery. Do you think the science would suggest that we should be doing this now, or do you think the science is not quite there? We got to sort of wait for clinical trials. And then sort of the same question for like an upfront surgical resection of Met. Do you think it's there, or we should be doing it now in lieu of either post-op or pre-op radiation, or do you think we still sort of need to wait and let a few of the trials play out?
Yeah, when I've discussed this in the past, I always highlight the fact that part of the strength of brachytherapy is that it's in conjunction with surgery. So the surgical component, I think, even in this era of modern FET and PET for the question of recurrence, there's nothing like actually having tissue, and I think it's fairly ubiquitous that we do a poor job with just imaging currently, and blood-based assessments, biomarker CSF, to be able to distinguish pseudoprogression versus true progression. So in and of itself, having surgery is great, and I do think the quality, though it's largely retrospective but fairly robust, a number of institutions routinely doing brachytherapy in the recurrent setting show excellent local control and safety profile. Perhaps the one challenge is that we don't have the length of follow-up that we necessarily have for radiosurgery, and now patients living longer. As the example I demonstrated, 5 years, 10 years out, seeing if that local control is preserved, even that far out, I think is important. But from my perspective, I do think it's something that should be considered in the certainly in the recurrent setting, and the data that we're seeing now in the upfront setting is very compelling in real world practice. And so I certainly would consider it and advocate for it in a practice that is logistically and technically prepared to be able to deliver that, both in academic practice and the community setting.
All right, just looking to see if we have any other questions from the audience. It looks like it said, "Thank you, Dr. Goodwin. Appreciate this panel is highlighting not only the biological and technical, but also the psychological dimensions of CNS and spine oncology. As a radiation oncologist, I often encounter similar situations where distress or decisional fatigue appears right around the time we're planning treatment, sometimes after multiple surgeries or recurrences when patients are emotionally exhausted. From a timing perspective, what do you think is the most critical window to identify and intervene on distress before it turns into treatment refusal or severe hopelessness? And how can we as radiation oncologists be more proactive in recognizing these early warning signs in daily practice?"
Day one, I mean, it really, one of the things that, I'm a very big proponent of is palliative care utilization. And I think that, what I've been actually, if you look at the Temel et al. Literature, as well as kind of all the studies, like it says that, the earlier you have these conversations, the earlier that they get engaged in the process, I think the easier it is to, for them to kind of understand all of the facets of care and decrease their overall distress. So I think one thing that I've been advocating for, with that said, is that a lot of these patients have somebody who is not a part of the treatment team involved with kind of establishing what their goals of care are, the treatment decisions, what are the different possibilities that they could come up with. And then I think that, kind of almost creating kind of, for lack of a better way of putting it, guidelines for themselves that they can then follow later on. Like, this is what I said that I wanted, right? Like, I don't know how often this is encountered, but, I frequently have patients who have like come in with DNARs and they are like, "Oh my gosh, I can't stop walking, I'm not gonna be able to walk. Can you do anything for surgery?" And then I basically, have a painstaking conversation with them about, okay, well, this is what the next 3 months of your life looks like. It's not just a singular event, it's all of the other things that go with it in terms of your rehab and the pain and all these things. And I found that when I have to have that conversation with somebody that I've had about maybe 20 to 30% of patients say, "You know what, you're right, maybe I don't want to undergo this." I think from the radiation oncology standpoint, I think it's probably doing everything that you're already doing, which is kind of partnering with all of your other specialties. I think, I actually talk to my radiation oncologist more than Trey Mulliken and John Kirkpatrick and all those, more than I do my surgeons, my fellow surgeons and whatnot, just because I think we share so many patients together through our multi clinic, everything else, that it makes it easy to start having these conversations. And one of the things that we did, this is the last thing I'll say about this, is that one of the things that we did is that as part of the Duke Center for Brain Spinal Metastasis, we decided to actually have a palliative care director, that their whole goal is to basically bring that palliative care aspect into the fold from the initiation. So, every one of the spine meds patients I see, they all see palliative care like automatically. And if they haven't heard about it, I'm the one that's saying, like, let's have this conversation. So I think at, diagnosis, usually, because they have a lot of information going at it. And I think that it's important for them to have individuals that they can talk to, not about their cancer, but about kind of how they're going to get through this process, so to speak.
Yeah, I think those are excellent points. Well, I know we're a bit over time. I do appreciate everyone's patience and engagement with listen to really what were excellent talks, obviously, but then just always love the conversational aspect of these panel discussions afterwards. So thank you to our panelists for taking a couple extra minutes with us. We do appreciate you. As a few closing housekeeping items, first of all, to our participants, thank you so much for coming and listening to these presentations this morning. We appreciate you. We're hoping that you gathered as much out of this that I know we all did as the organizing committee. Huge thanks to Janelle, who without her, we would not at all have had this come together and run as smoothly as it did this morning. So Janelle, huge tip of the cap to you. Thanks for all you do. On the same note, for everyone that is in attendance, you'll be getting an evaluation form that we would really love to hear your feedback. I really do feel like we have really made tremendous strides with how this conference has been run. The quality and expertise that we're able to present on these half-day sessions always continues to amaze me. And a lot of that actually comes from the reviews and evaluations that we get from our participants. So please take that evaluation to heart. We'd love to hear your thoughts on what we can do to make this better. Be looking forward to a save the date coming out for our springtime general CNS session that will either be in March or April. We are still deciding on a date. But with that, we'll close our conference, and thanks again to everyone for their engagement and participation.
Thank you, everyone. And also Chad and Caleb, thank you for all your technical help that always, we stumble, but you guys always come through. And we really take these reviews by heart. We have changed the conference as to who we invite, how we invite. So please fill those out, and really thank you for all the speakers for making, you all make the conference great. So thank you.
Bye, guys.
Thank you.